Dr. Neeraj is a consultant in Amrita, and he's going to talk about the role of allogenic stem cell transplantation in MDS.
Thank you. I would like to thank Dr. Biju and the organizers for giving me this opportunity to speak. So the topic is allogenic stem cell transplant in MDS. So I'll start from where Mayur has finished. You know that MDS is such a complex disease, and it is talking about one treatment. The forward that I can tell is that at least there are a cohort of patients who would not need a transplant. Also, there would be a cohort of patients who would not benefit from transplant. And then there will be a group of people who would benefit from transplant. And, so how we would go about this is, okay, we'll quickly go through the MDS subtypes, the limitations of the medical therapy that is available, and how the risk stratification is going to guide us, especially the IPSS revised, and the WPSS, which Mayur was mentioning, and which patient is likely to benefit from a transplant. And with the new information coming in with regards to the molecular mutation, what is the impact of the molecular mutations in a patient undergoing transplant? What should be the timing of BMT, especially in the context of therapy with hypomethylating agents like azacitidine, which are available now? And whether you should have a direct transplant, whether you should have a patient going for AZA or a chemotherapy prior to that. What should be the donor type, the conditioning regimen, whether it should be myeloablative or reduced intensity, and addressing the issue of relapse post-transplant. So is it actually one disease, the MDS? There are so many names, as Mayur was mentioning, the WHO classification in 2008 and the present classification, a lot of differences in the terminology now. And with regards to the treatment, it was largely supportive care, and then the drug which really made a difference in the outcome. This is the AZA 001 trial, which showed the significant difference in outcome in the survival when compared to the conventional care regimen. So even the best of the drugs that is right now available, it is modest response, and the average difference in survival is about 9.4 months. So as I said earlier, MDS is not probably a single disease. You can see in this slide the initial 97 Greenberg's classification of IPSS prognostic scoring system, in which you have a low IPSS score, which a median survival of 5.7 years. And if you have the other end of high IPSS score of 2.5 to 3.5, the median survival of 4 months. So you have in this marrow blast percentage, karyotype, and cytopenia were taken into account when calculating this. Now, the IPSS was revised again 15 years later, and here, as Mayur was mentioning, we have cytogenetics particularly into 5 groups, which a very good group as well as a very poor group, the very poor group having the complex cytogenetics. So here again, if you look at the risk stratification, now you have a very low risk group where the median survival is much higher, about 8.8 years, and you have a very high risk group where the median survival is at 0.8 years. So then we have the WPSS, the WHO's prognostic scoring. How it differed from the IPSS is particularly in the transfusion. It took into account the transfusion requirement. And if the transfusion requirement was defined as you require a unit of packed red cells at least once in every 8 weeks, and that those were considered as a higher risk. So with regards to the prognostic scoring, now we have the largest data from the IPSS. And in this publication way back in 2004, the figure up is the patients who were not transplanted, and the figure B shows the patients who were transplanted. Now, you can see that in the high-risk group, according to IPSS, those who didn't transplant had a dismal outcome, and that was similar for intermediate 2 risk as well. And there was a difference in those who were transplanted in these 2 risk groups. Whereas the other end of the spectrum, the low risk did bad after the transplant. So the low risk group, probably should not be transplanted according to this. The intermediate 1 group, there were 2 different studies, one which showed an improvement in the outcome in the transplant, and one which did not show an improvement with transplant. So, this figure would roughly give us an idea of whom not to transplant and who would benefit from the transplant. That is from the IPSS, and with IPSS revised, and we have a recent publication which shows the transplant outcome, in which the risk groups, other than the very high risk group, had the survival that is shown here. In addition to the IPSS stratification, the other thing which we would consider prior to taking up a patient for transplant is the comorbidity score. So now there is a hematopoietic stem cell transplant comorbidity index. And in this slide shows the same, and it has different scores attached to these. So based on the IPSS scoring, based on the cytogenetics, based on age, and the refractoriness to induction chemotherapy, there was this publication in 2014 which looked at the post-transplant survival, and there was an MDS transplantation index. So it took into account the age less than 50 years versus age more than 50 years, the IPSS scores. In addition to the IPSS scores, they have given particularly importance to the monosomy karyotype. If there's that was considered as an additional risk factor, and a HCT comorbidity index and refractoriness to induction therapy. So here, at least what we can see is that those who had a very high transplantation risk index did quite bad, and those who had high TRI and very high TRI did bad with the transplant, whereas those who had a low and intermediate had better responses. Now, coming to the molecular markers, which Mayur mentioned, there are some data now available with a few of the molecular markers and their outcome on transplant. So the TP53 mutated particularly do bad after a transplant. The TET2 and then DNM3A mutated do intermediate, and if you don't have a cohort of patients which these 3 mutations, they do better. So these are the 3 mutations which are found to have impact on the transplant. Now, if you have a karyotype and if you have a complex karyotype, now the IPSSR says the complex karyotype is a very bad risk. Now, if you have a complex karyotype and the TP53 mutation versus a non-complex karyotype versus a complex karyotype but TP53 mutation is absent. The group which did very bad was those who had a complex karyotype as well as a TP53 mutation. So These data are still evolving, and this data is on small number of patients, but these factors would help us guide in. So for example, if there is a patient who has a complex karyotype and a TP53 mutation, they may represent a group of people who may not likely benefit from transplantation. So with that, let us look at what is the current algorithm of treating patients with MDS. And the data on treatment is not always with a grade 1 evidence and the class A recommendation, but here this is what we would do in most of the patients. So we would have some patients presenting to us with asymptomatic and lower risk. Some patients would be lower risk with symptoms, and then a third group of patients would be higher risk. So an asymptomatic lower risk patient would anyway be observed very closely until progression. For a lower risk patient, who are the lower risk patients? Anemia with a deletion 5q, which Mayur was talking about. If you have an isolated 5q deletion, then that's a candidate to be started on lenalidomide. And there are some people who do not have 5q but still present with anemia. And if you have an erythropoietin levels less than 500, and they are known to 70 or 80% of them would be responsive to erythropoietin stimulating agents. And you may have other anemias who have a higher level of erythropoietins, in which you may consider lenalidomide, hypomethylating agents, or IST or supportive care. Some patients may present with other cytopenias where you give hematopoietic growth factors for a neutropenia, and there may be somebody whom you may give hypomethylating agent or immunosuppressive therapy or supportive care alone. So higher risk patient, transplant would be, again, considered only in a higher risk patient, and higher risk patient would be divided into a transplant candidate or a non-transplant candidate. We have based on the criteria that we mentioned before. And those for a transplant candidate, we would go for an allogeneic transplant and consider hypomethylating agent as a bridge to transplant. And for a non-transplant candidate, the option would only be a hypomethylating agent outside clinical trials. So if you have a patient such identified as a transplant candidate, and we know that in a transplant candidate, it's not easy to get donors. It's even for a sibling donor, if your patient is severely symptomatic, you may take time for the HLA typing, for the family to mobilize the resources for transplant, to search for an unrelated donor. So then the question that comes in is, should we give azacitidine prior to a bone marrow transplant? So there is a ASA prognostic score which involves the ECOG performance score, peripheral blood blasts, the RBC transfusion requirement, and the IPSS karyotype. So if you have a low ASA prognostic score, those are a subset of patients who have a median 2-year overall survival of 85%. And in such patients, we need not probably transplant immediately, and you could transplant if there is no response to ASA, or at the time of disease progression. Now, if you may have a patient who has an intermediate score, in which would try to deliver the usual 6 cycles of ASA and then proceed to transplant. Now, if you have a high ASA score, then that could guide us to give a bone marrow transplant as early as possible. Now, the other option for a young fit patient would be to probably who is presenting with a higher number of blast percentage would be to think about giving a chemotherapy. So there are no prospective trials on this, but then there is retrospective data published in chemo, those who have been given versus no chemo prior to transplant. And you can see that here that the group who achieved complete remission after chemotherapy versus those who didn't get chemotherapy prior to transplant, both the relapse as well as the non-relapse mortality were similar. So in this retrospective comparison, there was no difference in anybody who had received chemotherapy versus no chemotherapy and who had achieved CR. So how do we choose the optimal treatment before BMT in MDS? So this is a suggested algorithm. You could either wait, you could give hypomethylating agents, or you could give intensive chemotherapy. So if you have a comorbidities, a poor performance status, or if you have a patient with a very low disease burden, or if you have a progressive disease after the first-line treatment, a short interval to hematopoietic transplant, and standard conditioning, those are the times when we would wait. And for considering HMAs, if you have a patient with comorbidities, you would more, and if your poor performance status, your age is more than 60 years, you would swing towards HMA than the intensive chemotherapy in such cases. Again, as Mayur mentioned, the karyotype is one thing which would guide us. If you have a poor risk karyotype, then they wouldn't respond to chemotherapy, so maybe better to consider HMA in such cases, and for a good risk karyotype, you could go for a chemotherapy. And whenever you're considering a standard conditioning regimen, HMA probably is considered, and if you are considering a reduced intensity conditioning regimen, then, but these are not very clear. These are, debatable. So this is one of the algorithms that we could follow. Then there are some other specific subtypes of MDS, like chronic myelomonocytic leukemia, where there is good data to show that giving HMAs like azacitidine prior to transplant does, and achieving a CR prior to transplant does result in a better outcome. In therapy-related MDS, the transplant outcomes have been reported similar to the other subgroups. And in MDS with marrow fibrosis, the question which was asked before by, interestingly, there is data to show that if there is severe fibrosis, the severity of fibrosis adversely affects the transplant outcome. So it's better to transplant a patient before they develop severe fibrosis. And of course, we had the talk about the Fanconi, so MDS arising from germline mutation needs to be tackled differently with different conditioning regimens, so that needs to be specifically addressed. So this is the CABMTR data on MDS transplant over the years. And what you can see here is that transplant numbers have definitely increased. And if you look at the time, age group, I can see that, previously transplant used to happen in less than 50 years of age. And now the cohort that has increased is above 50 years and above 65 years. So more transplant are happening in more advanced age now. And what is the donor type right now? So here again, this is the CABMTR data on the donor type. HLA sibling transplant used to dominate, but now it is predominantly the unrelated donor transplants and a few of these haploidentical and cord transplants you can see here. So what is the outcome of the different donor types? The outcomes are definitely better in HLA identical sibling, followed by well-matched unrelated transplant, and followed by the others. Right, so now the question of what should be the conditioning regimen. Now there are myeloablative conditioning regimens like busulfan cyclophosphamide or TBI with cyclophosphamide. And then there are a lot of reduced intensity conditioning like fludarabine busulfan and fludarabine melphalan, the alemtuzumab based. So this paper in Blood in 2006 looked at a retrospective analysis of outcomes with standard myeloablative conditioning as well as the reduced intensity conditioning. Now, I just want to highlight this slide because this has divided it into less than 50 years of age and more than 50 years of age. And they have looked at, again, these two parameters, relapse as well as the non-relapse mortality. Now, if you look at the standard myeloablative conditioning regimen, the predominant problem was non-relapse mortality, and if age more than 50 years, has and non-relapse mortality of as high as 57%. Now, moving to RIC, the non-relapse mortality significantly comes down, but at a cost of relapse. So relapse is more than 50% in reduced intensity conditioning regimen. Now, if you decrease, you solved one problem but created another problem. So now we are trying to address the relapse, to prevent relapse. So there are two trials looking at it, the RELASA-1 and RELASA-2 trials. Essentially, the RELASA trials, what they're looking at is after the bone marrow transplant, they're looking at CD34 donor chimerism. And as you can see here, you can see the CD30, the total chimerism remains the same, but they're looking at the CD34 donor chimerism. And once it drops, serially monitored, once it drops, they're given azacitidine at regular intervals. And the early data from RELASA-2 trial was presented in last ASH, in 2017 ASH, and there are at least two cohort of patients who seem to benefit. In one group, the MRD was negative, and in another group of patients, the MRD remained stable. So it may either prevent relapse or it may delay the relapse. So those were encouraging. That we are still awaiting the full paper on that. So finally, the transplant activity in India, in the ISCTR, the 76 centers are there. I just looked at the MDS on the total transplants. So it's about 3% of the total transplants in the country. But if you look at the 14,000 transplants, it will be about 400 plus transplants of MDS. Maybe worthwhile looking at what have been our results on that. So to end, so this is the working group which has looked at guidelines, possible guidelines on transplanting MDS. So this was published last year in Blood. So if this is an algorithm, one for the low risk and one for the high risk. So if for a low, very low and intermediate risk IPSS, revised IPSS, then you look at the next thing you look at is the performance status. If you have a poor performance, go to non-transplant strategies. If you have good performance status, again, look at if you have a poor risk feature or a good risk features. If you have a poor risk feature, possibly like a cytogenetic poor risk feature or a molecular poor risk feature or blast percentage, and if you have an available donor, then it would be a transplant strategies. If you don't have a poor risk feature, a good performance, go for a non-transplant strategy. Failure, if you have a failure of a non-transplant strategy, then you would consider a transplant strategy in such a patient. In the other group, for a poor risk or a very poor risk revised IPSS, again, if you have a poor performance, non-transplant. If you're fit, then look for a donor. If you don't have a donor, go for a non-transplant. If you have an available donor, then the question is whether we should give azacitidine or chemotherapy. And if you have an increase in blast percentage, you could look at giving cytoreductive therapy and then follow it up with transplant. Otherwise, you could go for a transplant straight away. So I think with this, I would finish. Thank you.
Thank you, Neeraj. Questions from the audience? I think one of the big challenges I think that we face in India is the fact that unlike the West, where the median age of a patient with MDS is about 65, I think here it's about 45 to 50. So we see younger patients, and when we see younger patients, our challenge is to try and cure them. So my question would be, in the patients who have low-risk MDS, how many lines of therapy should they have failed for you to consider them for a transplant? Would they just fail one line, or you need more than 2 to 3 lines before you take them? These are transfusion-dependent anemias.
So for the low risk, if they remain in the low risk, or the question is whether they move on to the intermediate one risk as we follow them up. So by the time they fail at treatment, they might have already moved into an intermediate one risk. So it would be appropriate to assess them at the time of failure, and they may not continue to be at low risk anymore. And they may have acquired, new cytogenetic abnormalities, or so the recommendation is that at low risk, do not consider transplant. If there is a sign of a failure at the time, assess for other features of progression. And if they do progress to an IPSS-2, or if there are other prognostic markers which have changed over time, then we would definitely consider transplant at that moment. IPSS-1 also, it is very debatable. Even you could transplant an IPSS-1 patient. I mean, if a low-risk patient moves into an intermediate one risk also, probably you would consider if they have failed treatment.
Oro.
Thank you. It was a very nice presentation. So just one or two things, probably a bit controversial. So just with the expansion of Biju's question, would you not consider taking someone for a transplant who is a low risk, but who is severely thrombocytopenic, or anemia requiring transfusion, because we know that azacitidine will not work in that group, or a low-risk patient who has got fibrosis in the marrow, because he may come into IPSS, or IPSS are low risk, but we know that with a significant fibrosis, that person may not show a good response. Or third category, who will be a low risk, but who has got a high-risk cytogenetics, or a high-risk complex molecular signature, who has got a sibling donor who is young. Would you consider this group for transplant?
Yeah, so very good questions, sir. So in the low risk group, especially if they have fibrosis, the answer is that in fibrosis we have definitely data to show that if the fibrosis is early, and if once you have a delay that once your fibrosis becomes severe, your transplant outcomes become really bad. But the problem is we do not have any recommendations or studies on which we can recommend this. But yes, we would consider a patient with fibrosis, thrombocytopenia, even if they remain at low risk, because IPSS probably doesn't take into account of these specific issues of thrombocytopenia as well as fibrosis and its impact. And the other question is regarding the complex cytogenetics. Definitely the newer recommendations is very vague on that. They say if you have poor prognostic features developing in a low risk, consider transplanting. So that I guess would mean a complex cytogenetics as well as a complex cytogenetics plus a molecular mutation like TP53s.
I agree with what Oro says in terms of thrombocytopenia. So in what we have found in clinical practices, if you have a hypercellular marrow and you have severe thrombocytopenia related to the MDS and dysplasia, they do not do well with either lenalidomide or any of the other therapies. But if you have a hypoplastic MDS, even if it's severe thrombocytopenia, they may do well with cyclosporin or ATG. So I think if you have hypercellular and severe thrombocytopenia, that may actually be an indication to take them up for a transplant early, especially if they have a match sib available. I agree with you on that.
So one of these things which in the panel which is recommended is that thrombocytopenia less than 30,000 and ANC of less than 800 and transfusion dependency probably indicates poor risk and progression. Those who were not, if your thrombocytopenia was above 30,000 when you started and then it drops to 30,000 and less, and if your ANC drops to less than 0.8 and transfusion dependency develops, at that moment probably we could consider.
Ashish?
Thanks, Neeraj. Excellent talk. Unlike Oro is from the west, I'm from the far east, but I agree with what Oro is saying. I think the real life caveats are these patients, if they are cytopenic, we will consider them for a transplant much earlier. But I just like to draw your attention to a point. You said in some circumstances you would wait for failure of azacitidine. Now, that's a difficult situation. You really do not have much to offer a patient after azacitidine. And when they are on azacitidine and responding, if they are transplant eligible, transplant suitable, maybe your best opportunity to take them up for a transplant as a curative treatment. We don't know what the long-term responses of patients. There's a small cohort, I agree with you, based on the scores that you put in. We've had patients who are going on azacitidine for 4 or 5 years, but invariably we see that they start running into trouble. And then you've got the competing problem that these patients are aging up also. So you're building upon their comorbidity scores and their transplant-related mortalities. So if you got a patient who's suitable for a transplant, I think the transplant considerations in MDS should be upfront. You might use azacitidine to reduce your blast burden and get it less than 10% to improve their chances and reduce the risk of relapse after transplant. But we would usually consider them much earlier rather than wait for azacitidine to fail.
Absolutely. So this is just one of the scores which has been, you suggested that, azacitidine in that subgroup which showed benefit to azacitidine was probably 85% of them had more than 2 year doing well on azacitidine. So it's really difficult because when you take somebody up for transplant and then you have a 20 to 30% non-relapse mortality with the transplant, and you have a treatment which may keep them well for 2 to 3 years. It's a difficult call to make at that moment. Things are clear only in the extremes where the timing of transplant is always controversial, and it has not been really shown that if you actually wait for the whole cohort of MDS patients with either chemotherapy or azacitidine, that the outcomes will be different.
So let me ask this question to Ashish and Auro because they represent 2 different continents. So one of the challenges, like you mentioned, is when we're using azacitidine as a bridge. So somebody who's got, say, 18% blasts, and then after the 3 cycles of azacitidine, it's come down to, say, 12%. There we can sit and debate, should we take them up now for a transplant? Should give another 3 more cycles and then see if you can reduce the blast percentage down more before you actually take them up. So what would be the practice in Australia and in Canada? Ashish and then Auro.
Okay. We like to get it less than 10%, but the fact the person responding and got down to 12%, we'll start planning for a transplant already. And by the time we get the donors sorted out and roster the patient, it's likely they would have had 1 more 2 cycles. We'll repeat a bone marrow before that and go ahead with the transplant.
And the second question, and I want Auro to answer this, so would you look at sibling, mud, and haplo, or would you say if he's doing well, only if he's got a sibling or a mud donor, I would stop there?
So that's where your cytogenetics and genomics comes in play as well. And if I've got somebody with adverse cytogenetics who's responding to azacitidine or has got an adverse p53 mutation not sitting there, I will look at all options. I'll be speaking a bit in the AML talk, but in MDS also they're now showing that though the follow-up of the haplotransplants is always shorter than all the other cohorts, the curves almost reach up to there. I guess we have to wait for a few years till we see mature data on the haplotransplants coming up from the sector.
Auro.
So Biju, 2 things. First thing is that 18% blast to start with is a bad disease in the beginning itself. So we do not look at the marrow unless the person has completed at least 4 cycles of azacitidine. So after 4 cycles, 2 scenario, less than 10%, definitely, irrespective of a type of donor to take for transplant. More than 10%, if the person has not shown a good response to the 4 cycles of azacitidine, we change the gear and we go ahead with the induction chemotherapy. At that time, we're giving an induction chemotherapy if that person is able to tolerate, because after 4 cycles, if from 18% it has gone down to 14% or 13%, then addition of a azacitidine continuing another 4 cycle is we're just probably delaying the transplant rather than giving induction chemo if he's showing a good performance status. achieving it less than 10, and go ahead with the transplant.
So do you have a cutoff of age on when you would give induction? So would you go up to 65 years?
We are now giving even up to 73, 74 years,
Okay.
full dose including flag IDA. So some patients with up to 70 years plus.
Canadian patients are different from Indians. I don't think anybody will.
But at least up to 70 years,
Yes.
we will definitely give. Second thing is that about the type of a donor. To start with, we're already with a 18% blast, that person is a high risk. So even if our preference will be sibling or a 10 by 10 donor, but if we have got a 9 by 10 donor who has not shown appropriate response after 4 cycles of azacitidine, we would still go ahead with a 9 by 10 or a haplo.
So if it is not for a reduced intensity conditioning, for a reduced intensity conditioning, blast percentage may really matter. But if it's not a reduced, if you're going for a full myeloablative conditioning, there's not data to show that the blast.
So for us, we would give the 3 cycles, but at the end of 3 cycles, even if it's 10 or 12%, because we're going to do myeloablative, we do not wait for it to come down below 10, because unfortunately, each cycle of azacitidine also keeps on adding to the cost pre-transplant. So if at the end of 3 cycles, they still have not reached less than 10, we would go ahead with the transplant, but we would definitely do a myeloablative conditioning and go ahead.
Sure.
Riaz,
Sir, Dr. Aro just said 7-3 induction regimen, sir. Just wanted to ask, any role of adding venetoclax instead of
Aro,
7-3?
anything about adding venetoclax to the...
Azacitidine plus venetoclax.
All these things at present are still research question. Those will not be considered as standard. Depends on the availability of a trial in that center, but I would not probably generally recommend that everyone should get it.
I think there's also a trial going on using azacitidine plus rigosertib, it's a RAS inhibitor, after those who fail hypomethylating.
So
Ashish.
on the question of adding venetoclax, so there's a trial going in Australia where they're combining venetoclax with 7 and 3. And the data, it's going through cohorts, it's going through dose escalation. Andrew Way is the PI running through. What we have seen is that venetoclax does increase the period of cytopenias. So it's not as straightforward. In fact, the trial that's been designed is patients getting venetoclax, plus they get a 5 and 2, they don't get a 7 and 3 actually. And then in consolidation, they get a 2 and 1, and still we are seeing a lot of prolonged myelosuppression with that. So it's not as straightforward just mixing 2 drugs. The potential implications are a lot. And in our MDS cohort, the very fact that when you try to give them induction chemotherapy, you have to prepare yourself for prolonged cytopenias. They may not recover. I wouldn't jump into that here. Yeah.
And Biju, don't mind if I'm incoherent because it is 3:30 a.m. for me now.
No, just I was curious to, one of the slides you mentioned that the very high risk not to transplant, that is the high risk cytogenetics and P53. And you also know those group of patients respond well to the hypomethylating agents. So can you clarify on that particular slide you mentioned?
That was a few, I think the numbers were very small on that, but then that's one of the papers which published in JCO in 2014, which looked at the 3 different mutations and the karyotype. So if you had a complex karyotype and a P53 mutation, and they are all undergone transplanting. So that particular set of patients did bad with the transplant. That's all that we know right now.
But still, those group of patients need to be transplanted.
If you had a P53 mutation, you did badly. Even if you did a transplant, you did badly. But there is now some emerging data to show that decitabine actually works very well with the P53 mutation. And so there is actually a Chinese study where they have incorporated decitabine into the conditioning regimen and given it post and shown that in the P53s it actually works. We need to see more data. Any further? Ashish.
P53 mutation story. So if I have a 69-year-old or a 65-year-old person who's got a P53 mutation and comes for a transplant, I'm going to say what Neeraj says, that the outcome with transplant is going to be poor. That won't be the recommendation for a 40-year-old person if he's got a P53 mutation, where I will go ahead with a myeloablative transplant and then try to post-transplant either immunomodulate him or use strategies to actually improve the outcome.
Any further questions? If not, thank you, Neeraj. We'll come to the end of this session. It's now time to break for lunch. lunch is served outside. There are going to be box lunches, and as a part of the initiative to go green, these are biodegradable boxes that you will be getting. We will meet back at 1:45 for the transplant session, 1:45. Thank you.
Minutes, which is a big topic, but let's start. So that's my disclosures. The other disclosure that I would like to add on the same lines like Oro, I've landed at 9 o'clock in the morning here today. So I'm getting into Melbourne evenings now. Now, allogeneic stem cell transplant, we all know, is the most potent anti-leukemic therapy. And in a new era of immuno-oncology, it would be fair to say that's the oldest immune therapy that we know about, and it is very effective in AML. And that the curve on the left, the Kaplan-Meier curve on the left, is some old data from Mary Horowitz in 1990 showing that clearly when patients had graft versus host disease, the relapse rates were significantly lower, clearly depicting a graft versus leukemia effect or a graft versus tumor effect. Now, despite not having any new medications in our armamentarium, we have improved the outcomes of patients with acute myeloid leukemia. And that's because we have improved our supportive care, management of infections, identification of patients who are suitable for intensive treatments, but also, to some extent, this improvement in outcomes is because of identification of patients who will actually benefit from an allogeneic stem cell transplant and timing the allogeneic stem cell transplant at the right point. So what are the factors that we take into account when we are recommending an allogeneic stem cell transplant? And it all starts with the disease that we are dealing with. What's the risk stratification of the acute myeloid leukemia we are talking about? What's the stage of the disease? Whether there are any alternate treatment options that this patient has? And quickly rolls into whether what are the patient factors that we are going to be dealing with? What's the age, comorbidity, and other risk factors that may increase the toxicity or mortality for this patient? Other considerations are, do we have a donor for this patient? What are the stem cell sources we are going to use? What are the conditionings we are going to use? What's the graft versus host disease prophylaxis? And we put all this together aiming for a success of a transplant. Of course, the two impediments to it are the non-relapse mortality, which is a significant hindrance, but also the other big relapse in acute myeloid leukemia is relapse of disease post-allogeneic stem cell transplant, which is also a very substantial problem that we have to work on. Now, the first question is, when is it the right time to transplant a patient with acute myeloid leukemia? And the answer is CR1 is the right time for the right patient. And the curve on the left is data from the ECOG studies looking at outcomes of patients who had a relapse and the survivals of those patients. And it's very obvious that the survivals of these patients, even in the younger patients, is very dismal. So the fact remains that the best opportunity to transplant a patient with acute myeloid leukemia is in CR1. And the question is not when to transplant the patient, but the question is whether you should transplant the patient or not. This was supported by the prospective HOVON study, which was a donor versus no donor analysis, which was a biological randomization, and that showed clearly that the patients who had a donor with the intent to treat analysis had a superior overall survival as compared to those who did not have a donor. Further, adding to that data is the meta-analysis from John Korath, published in 2009, looking across at 24 trials and looking across various cohorts of patients in standard risk, intermediate risk, and poor risk AML, and giving the signal clearly that the overall survival benefit improvement was seen in patients with intermediate risk AML and poor risk AML when they were transplanted in the first remission. The benefit could not be demonstrated in the favorable risk acute myeloid leukemias, and hence transplant is not considered for patients in this group. We've all along this while known that AML is a heterogeneous disease, and the paradigm is that the different karyotypes in AML are responsible for different outcomes. And broadly, it is possible to categorize these different outcomes into three categories. The good players who have a good response and a long-term survival, more than 60 to 80% post-chemotherapy, which we call the good risk AML. The really poor players or the adverse risk AML, where the survival post-chemotherapy is in the order of 10 to 20%, and the intermediate players which the survival is intermediate between the good risk and the adverse risk. And the normal cytogenetics, which constitutes 40 to 50% of patients with acute myeloid leukemia, sits very well in this intermediate risk category of acute myeloid leukemia. Of course, these are not the karyotyping is not the only risk factor that we are taking into consideration. There are other disease risk factors like the high white cell count at presentation, delayed achievement of CR or non-achievement of CR after induction chemotherapy, extramedullary disease, and transformed acute myeloid leukemia, which are also equally adverse risk factors, indicating a poor disease biology and making them candidates for a transplant. But what's changing in acute myeloid leukemia? And the three things that are changing in acute myeloid leukemia are the amount of genomic information that we are now getting on our patients when they are diagnosed with acute myeloid leukemia, the improvement in the tests that we've got to measure the completeness of response. We have now very robust tests to measure what we call MRD, or minimal residual disease, or measurable residual disease. And what's the impact of the targeted therapies, the new drugs that are coming in AML, will have on our decisions to transplant patients. Now, the genomic and epigenomic landscape was outlined by the Cancer Genomic Project, which looked at the genetic mutation profile in AML and found more than 200 recurrently mutated genes. And there were some frequently mutated genes which were about 23 in number, and there were around more than 200 genes which were less frequently mutated in acute myeloid leukemia. And these could be broadly classified into fusion mutation suppressor genes, DNA methylation genes, activated signaling, the chromatin modifiers, the cohesin, and the spliceosome genes. But what kind of information can we expect that this genomic, this mutational data will give us? I think we are looking at identifying whether some of these genes are the driver genes in acute myeloid leukemia. These are the driver mutations and both targeting. Are some of these genetic mutations, can they be direct therapeutic targets from drugs like the FLT3 inhibitors and the IDH inhibitors? Are some of these genetic mutations just prognostic markers which will help us tell us who are the patients who will do poorly with chemotherapy? And are some of these genetic mutations actually measurable, telling us what the biology of response or the depth of response of our patients are and are suitable for minimal residual disease? Putting all that information together, we can end up with a really complex equation where we can have cytogenetic and molecularly defined subsets of AML, and we have managed to break those three categories that I spoke about into a lot of more subcategories. And so when we talk of a T53 mutated AML, we can talk of T53 mutated with complex karyotype, without complex karyotype, and expect that the survivals of these groups are going to be slightly different. Now, the paradigm when the information or the molecular information was limited was straightforward, because we had information on NPM mutations, we had information on FLT3 mutations. We knew FLT3 mutations or FLT3 ITD mutations are poor players and are good transplant candidates because the survival of these patients improves after they have a transplant. We also knew that mutated NPM1 is a good prognostic risk factor, and hence these patients do not need a transplant. There is no additional survival benefit of doing a transplant on these patients. But what happens when you throw in a few other variables? Let's see, some of these patients have got a DNMT3A mutation, some of them have got a P53 mutation, some of them have got an IDH mutation. The equation now is getting a bit more complex rather than a simplistic equation we had. And this is reflected in the ELN classification, the most recent one published in 2017, where we maintained the three different categories, the favorable, the intermediate, and the adverse risk. But if you look into each of these categories, we are now looking at the combinations of these mutations. When you have a mutated NPM1 with a wild-type FLT3 ITD, it's a favorable risk. When you have a double mutated CBPA, it's a favorable risk. Similarly, we have split up the intermediate category into NPM1 mutated, either with a low allelic burden, and when they have a high of FLT3 ITD, and when they have a high allelic burden, or if we categorize it at an adverse risk category. So it's possible now to split these into various groups. And when we receive this kind of information and are asked to make transplant decisions, it can get fairly complex. So while we are now looking at molecular information, which is going to tell us which patients are good, intermediate poor, and very poor, and we are very clear that the good risk patients are the ones we won't offer a transplant in CR1, we can hope that in future that we will have a personally tailored risk prediction score. This paper that was published in Nature Genetics looked at 230 clinical variables, including mutational on more than 100 genes. And they created an algorithm as a research tool that would tell us if that the patient was transplanted in CR, what was the chances of them being alive in remission, what was the chances of their having a relapse, what were the chances of their having a non-relapse mortality. And this is available as a research tool, purely as a research tool, not as a decision guiding tool online. Now, one of our medical students who wanted to do a project with us did this interesting project. We were very keen to see what would this impact have on our decision-making ability. And we identified a cohort of patients who was an ancient cohort of patients where when we were making decisions for transplants on this cohort of patients, we had information on NPM1, FLT3-ITD, and CBP mutations. Subsequently, however, we had next-gen sequencing information on this cohort of patients, and this medical student actually looked at plugging in this genetic information into the algorithm and seeing whether it would change the transplant decisions purely on the risk stratification. And his conclusion was that the incorporation of the extended genomic information, where we would accept more than 5% gain threshold in the outcomes of the patient, had the possibility of altering our decision-making in almost half the patients that had a transplant. Now, this was a very small cohort. It was only a 64-patient cohort, so we cannot really translate in our transplant decision-making, but does give us a reflection that as we are getting more and more genomic information as standard practice, and next-gen sequencing is expected to become standard practice, we will have a lot more complex variables to deal with to make decisions based purely on the disease biology or the mutation profile. Now, I spoke about the incoming information about the genomic profile, but what about minimal residual disease? And minimal residual disease, or as some people call it, measurable residual disease, it's the ability to measure the depth of response that we've achieved. And there are different tools with a different sensitivity that can tell us that. We have multi-parameter flow cytometry that can do it to the depth of 1 into 10 raised to 4. We have RT-PCRs that can do it in the depth of 1 into 10 raised to 5. And these are well established in acute promyelocytic leukemia and core binding factor acute myeloid leukemias. And then we have next-gen sequencing, which can be used at minimal residual disease, which can give us a depth of response in 10 raised to the power 6 or 7. So really a very sensitive test. And of course, there are issues with these tests. These have to be standardized. The results have to be reproducible. There has to be good quality control. The targets that are used for minimal residual disease have to be very stable. The timing of minimal residual disease is very important. And there is always the limits of the testings have to be very well defined. So let's look at what minimal residual disease has got to offer us. And this paradigm has been well established in acute promyelocytic leukemia. It has been well established in core binding factor leukemias. This was a French study done by Jordan that was looked at various parameters that might influence the outcomes of patients, which are defined as good risk or a good prognosis acute myeloid leukemia, the core binding factor acute myeloid leukemias. They looked at a high white cell count, KIT mutations, FLT3 mutations, and also a less than 3 log MRD reduction after first consolidation were the parameters that they found were correlating with the increased relapse risk. And when all of that was put into a multivariate analysis, the one that stood out the strongest was the minimal residual disease positivity after consolidation, showing that we could identify a patient even in the good players or the standard risk AML, who by virtue of having an incomplete depth of response were likely to relapse in the future. Similarly, NPM1 mutated AML, another standard risk AML or a good risk AML that we would not be offering a transplant in absence of any other mutations in CR1. And this paper from the UK group by Adam Ivy looked at NPM1 MRD after chemotherapies. And they could clearly demonstrate that if patients were MRD positive after the second chemotherapy cycle, these patients were likely to have a high incidence of relapse. Now, this was irrespective of whether these patients had a FLT3 mutation or a DNMT3 mutation, and they could not demonstrate any additional benefit of these mutations. What all this tells us is that while we now have a tool that we can actually monitor. So in the future, we can see a patient who's NPM1 MRD positive after the second cycle of chemotherapy. He probably needs sequential monitoring of his MRD to see whether the MRD levels are increasing. And if the MRD levels are increasing logarithmically, then he's at a high risk of relapse, and transplant might be a consideration in some of these patients. What about the newer drugs? So the newer drugs coming in after decades and decades of toying around with chemotherapy and adjusting the dose of various chemotherapies, finally we can talk of some newer drugs in acute myeloid leukemia. And the ones that have been approved by the FDA recently are the FLT3 inhibitors, midostaurin, the IDH1 inhibitor inacinidib, the IDH2 inhibitor inacidenib, and the IDH1 inhibitor ivosidenib. Gemtuzumab osagamycin, which has been an old drug and has been kind of rescued, also has been approved for relapsed refractory AML. Then we've got CPX351, which is a liposomal formulation of satrabine and daunorubicin, which has been approved for therapy-related AML or AML with dysplastic changes. I just want to spend a couple of slides on the RATIFY study, which was the phase 3 randomized study of midostaurin, and see what impact that this information may have on a decision-making process in the future. Now, the RATIFY study was a phase 3 study. It randomized patients into a chemotherapy plus placebo, a chemotherapy plus midostaurin. Patients received midostaurin in induction, in consolidation, and then went on to have a maintenance phase. Patients were allowed to have a transplant, and those who had a transplant did not continue any midostaurin. The rate of CRs in the midostaurin group was 59%, which was comparable to the 53% rate of CRs in the placebo group. And the allogenic transplant rates in both the groups were also comparable. But the survivals were found to be different, and the 5-year survival rates for the midostaurin group was 50% compared to 44% of the placebo group. The median follow-up was robust of around nearly 5 years for this group of patients. So clearly showing that establishing midostaurin as a gold standard in the management of patients with FLT3 mutated acute myeloid leukemia. Now, if you look at what the transplant data was, although there were only 25 odd patients transplanted in each arm, it's clearly apparent that the group that had transplants in CR1 continued to do better than the groups who had transplant beyond CR1. Thus, maintaining the paradigm that even if we have now midostaurin in our therapeutic armamentarium to treat FLT3 mutated acute myeloid leukemia, the paradigm of transplanting these patients in the first remission still continues. Does midostaurin impact when NPM1 mutations are present? And this was a small cohort study. The study was not powered to look at this subgroup of patients, but this was a subsequent analysis that was presented in ASH that looked at what happened when there was NPM1 mutation present with FLT3-ITD mutation. And the group that seemed to do the best was the one that had an NPM1 mutation with a low FLT3-ITD ratio when they got midostaurin, thus making us wonder whether this group is a group of patients that can potentially be monitored with MRD subsequently and may not require a transplant. We still would like to see more robust data, but these are some of the things that are now being thrown at us in terms of the newer drugs, the newer techniques, and the tests that are now available to us. So where do I see the impact of these novel drugs? I see them improving responses. I see them improving survival. Will they reduce allogenic stem cell transplant? Yes, that's the hope, but we do not have any data to support that right now. I certainly see these drugs increasing the number of patients we are going to bridge to transplant. For patients who are relapsed and have got an IDH1 mutation or IDH2 mutation, we've got now drugs to give them, get them back in remission and offer them a transplant if they did not have a transplant at the first go. We potentially can use these drugs to optimize their disease status before transplant. If patients are positive for minimal residual disease, then these drugs may be used to optimize that. And the last thing that I foresee these drugs being used is to actually improve post-transplant survivals, and I would speak on that in the subsequent slides. Now, there are some real-life caveats which are important in any transplant, and they are the patient risk factors. I'm not going to spend a lot of time. Neeraj spend some time on this, talking of the comorbidity index. That's an important score for us to look at patients. Age is no longer taken as a risk factor. The CIBMTR published the data on patients older than 70 who were transplanted and could show a 35% survival. So the real deal is to look at the comorbidity scores, and especially in elderly patients, the increasing role of doing a comprehensive geriatric assessment in these patients. The other real-life caveat is what kind of donor we have, and this issue is getting solved because we have donors for nearly everyone now. With the broadening of the haplotransplant and the uptake of haplotransplant in a lot of centers all over the world, we can find donors for almost 95% of our patients. The preference still remains as minimal residual, the preference still remains for match-related donors and 10 out of 10 mud donors. And haplo, cord, and mismatched donors would be considered alternate donors. But improving transplant techniques, we can expect the outcomes of these transplants to be similar to match-unrelated donor transplants. The conditioning issue, the only point that I need to focus here is that RIG transplants has allowed us to offer transplants to a lot more patients. It's feasible to transplant the elderly patients. The RIC transplants focus mainly on the graft versus tumor effect, but there is a caveat there that retrospective studies have shown that they are associated with a high risk of relapse. Newer drugs like triosulfan and radiolabeled antibodies are making their way into conditioning regimes. So is the jury out on the conditioning of patients in acute myeloid leukemia? And the Kaplan-Meier curve on the left is a randomized study done by the BMT CTN network that looked at MAC conditioning versus reduced intensity conditioning. And if you look closely at the lower part of the Kaplan-Meier curve, the significant difference in the relapse rates and the higher risk of a relapse with reduced intensity conditioning gives the signal out that patients who are fit should receive a myeloablative conditioning. Should these patients receive a TBI conditioning? Should it be an BU conditioning? Should it be an IV BU conditioning or oral BU conditioning? And a retrospective study from the CIBMTR has looked at that, and they found that with BU PK pharmacokinetics, the outcomes were superior with intravenous BU and cyclophosphamide. The last question is BU size still the gold standard, or flu BU has replaced it? And again, this was a study that's been published in Lancet Oncology, which looked at a randomized comparison of BU-Cy as conditioning and flu-BU as conditioning. And while the relapse-free survivals of the two groups were similar, there was less transplant-related mortality in the flu-BU group, saying that for patients when flu-BU is used, we could get away with lesser transplant-related mortality. The last few slides, I'm going to just focus on seeing what avenues we have about reducing relapse in patients with acute myeloid leukemia. It's still a significant problem, and there are clearly some high-risk patients. There are some adverse ELN risk patients like a P53 mutation, where the risk of relapse after transplant is as high as 70 or 80%. Patients who are MRD positive pre-transplant and patients who continue to remain MRD post-transplant also are at risk of relapse. Patients who have a reduced intensity transplant clearly have a higher risk of relapse as compared to a myeloablative transplant. What are the strategies we can use? Some of these are old strategies like earlier taper of immunosuppression, but cellular therapies, mainly donor lymphocyte infusions and pharmacological therapies are making their way there. Donor lymphocyte infusions, now these could be delivered in a prophylactic way where we are not monitoring MRD, we just have a set protocol and we start giving them donor lymphocyte infusions after we have identified a patient who's at high risk of relapse. It's usually recommended to be done in context of a clinical trial. It's usually advised in T-cell depleted grafts. The other option, of course, is to use preemptive DLIs where we can monitor MRDs or we can monitor chimerisms and give them DLIs. Now, the DLIs could start at a dose of 10,000 to 10 raised to 1 million, depending on what kind of transplant or the level of mismatch with between the patient and the donor. And again, the frequency could be very variable between 6 to 8 weeks. And invariably, each center develops its frequency about how they want to deliver preemptive DLI. And this is just an algorithm as a guide that's been put out by EBMT for how to use these. The main questions to be asked is which patients. Are we going to target patients who are MRD positive post-transplant? What dose we start them on? What frequency do we give them? And what's the endpoint? When do we stop? Do we have a measurable endpoint in terms of chimerism, or we stop when they start developing a bit of graft versus host disease? And these are difficult scenarios. There is never a right fit for every scenario. Each situation has to be individualized. But the most exciting thing is happening probably in the pharmacological manipulation. And there are a few drugs now coming in which are effective. Now, Neeraj spoke about azacitidine. It's a drug that's tolerated post-transplant. There's an immunological basis to use it because it improves the Treg constitution, reduces graft versus host disease, but at the same time improves the CD8 T-cell response to the leukemia antigens. The RIC-AZA study is a study by Charlie Craddock that looked at a reduced dose of azacitidine as a maintenance strategy after transplant. The REL-AZA study is a study which looked at CD34 chimerisms when they dropped less than 80% and used azacitidine in a preemptive setting. There's, of course, also oral azacitidine that's making through, and we are waiting the outcome of a phase 3 study to look at to demonstrate the efficacy of this situation. Most of the data that's available is in phase 2 studies. The other drug which can be used, of course, is lenalidomide, which can potentiate the graft versus tumor effect. It's been shown in a phase 2 study at a dose of 10 milligram. One of the expected side effects is the graft versus host disease risk to the tune of 30 to 40% that it can cause. There's a study that we have currently ongoing in Australia at my center where we are looking at a micro-len study. We are looking at really small doses of lenalidomide and see whether we can modulate graft versus tumor effects for these patients. But the targeted therapies are also making their waves here. And the Kaplan-Meier curve on the left is just a retrospective study looking at use of sorafenib in a very small cohort of patients. And these were then compared to a group of 50 controlled patients. And they could clearly demonstrate when they use sorafenib, which is a multi-kinase inhibitor, in patients who had a transplant for FLT3 positive acute myeloid leukemia, they could significantly improve the survivals of these patients. There is an ongoing phase 3 study of using a second generation FLT3 inhibitor, gilteritinib, versus placebo. It's going on in a lot of centers in US, Canada, and Australia. And there's a German study which is looking at midostaurin in pre and post transplant status as for a maintenance therapy in acute myeloid leukemia. So some strategies are coming up. Lastly, to conclude, the scenario for allogeneic stem cell transplants in the AML is changing. There are molecular mutations, MRD testing, and newer drugs. We would still recommend a transplant in AML in CR1 in intermediate and high risk, but what's changing is the definition of what's intermediate and high risk. A transplant is not recommended in the favorable risk group in CR1, but MRD should be utilized in these patients to identify patients who are likely to relapse. MRD monitoring should be used pre and post transplant. The preference in conditioning is the myeloablative conditioning, and the focus has clearly to be on strategies to reduce relapse after transplantation. That was my last slide. Thank you.
Thank you, Ashish. Questions from the audience? Akusratna.
Thanks for the nice talk. I need a clarity about the MRD. We all know that MRD now is very important pre-transplant, and the chances of relapse are very high in MRD positive. But when you transplant a patient with MRD positive, you also know the relapse post-transplant is quite high.
That's true.
So what do you do in the MRD positive situation? It's a paradox. Do you want to render them MRD negative before transplanting, or what is your strategy?
It's a very good question, and I don't have a straightforward answer to your question. I can draw a parallel from ALL, where there are drugs that can get patients MRD negative. For example, you've got blinatumomab, which will get patients who are MRD positive to MRD negative. But even in that situation where you've got a drug, the data is out there. We have these meetings, leukemia meetings, where we sit regularly with our pediatric colleagues. And our pediatric colleagues are very clear. In ALL, they would target MRD and do anything to eliminate MRD before they take a patient in transplant. But the adult team, we are not so focused on that. Unless we see robust data that we can actually get rid of MRD for sure in these patients, it's difficult to delay a transplant because you might be losing an opportunity to transplant a patient. So at this point of time, the only way I see it being done is in a clinical setting, in a clinical trial setting. I don't think we can employ it right now in standard treatment settings.
Super.
So I think it has to be decided based on what's the molecular mutation that you're dealing with. So you can, when your standard risk AMLs, in APML, you've got your PML-RARR. In core binding factor leukemias, you've got the AML ETO1, the CB5 MYH11, or the NPM1. All these are standard risk. And so you have to, these are stable targets that can be monitored for MRD. How frequently? I think every institution has to establish it, but the way we had established that we will monitor MRD for at least 2 years, and we try to do it every 3 months. Yeah. The burden is that you get these phone calls from the lab saying, do we really need to do these marrows every 3 months on these patients who are in morphological CR?
Suparna?
It's behind you. Yep.
I don't know whether you've seen our publication in BBMG and a couple of other places on relapsed refractory AML.
I've heard Sarita present, Sarita just were present in the tandem meeting. Yeah.
I mean, there would be good 30% patients who won't achieve CR
Yep.
after standard 3+7
Yeah. Yep.
in AML, and you are left with a group of primary refractory.
Very true.
Relapsed refractory. So that's the population
Yep.
we deal with on a regular basis. And I fully agree with you that doing a myeloablative procedure is a must. That's number one. I mean, that's a must. I mean, you cannot in an active disease, whether it's, I mean, when we are talking of MRD,
Yep.
I mean, there is no point in talking of rate in MRD positive. I mean,
Yeah.
we are talking of florid blood, so
I agree with you. Yeah.
we have to do a myeloablative. But what is most important, I mean, in my mind, is that we have to have strategies where we can induce a strong GBL effect without having acute GVHD. And there I concur with you completely that the pattern of chronic GVHD we see in our population is limited chronic GVHD. And in the West, where we have all worked for a long time, we see pretty bad
Yeah.
multi-organ GVHDs, which is not skin limited or ocular limited or mucosa limited GVHD, which one can live with. Now, saying that, it's important to transect the GBL GVH effect. And I think one of the best ways of doing it, AML, I mean, I'm talking because it's AML,
Yep.
is through NK cells.
Yeah.
And if we have to look forward in AML, how we can get a potent GBL effect without inducing GVH has to be through NK cells. So, I mean, we have got several publications on this, and we are pretty convinced at this point of time that you can do it through NK cells.
See, Suparna, I agree with you, and the NK story in AML has been there for some time. You go back to the Haplo publications in NK cell where they looked at the NK ligand and showed this. I just had 25 minutes. I can't cover everything on this in the 25 minutes. So, and see, that was my last slide saying that we have to push for more strategies to reduce relapse. We are identifying the right patients to transplant, but relapse is still a significant issue that we have to deal with. And yeah, as the data matures, I'm sure it's going to be robustly discussed as well. Yeah.
Ashish, two questions. One, what is your cutoff for using for RIC, and any experience with the use of gemtuzumab during conditioning?
So second question, no, we have not incorporated gemtuzumab. I think the concern always is if you're going to involve gemtuzumab in the equation, whether end up with VOD. So we haven't involved, though we can access gemtuzumab as an access program, but our use has been very limited in there. You mean the age cutoff for RIC?
Yeah, so when do you decide between RIC
and
do you have an
myeloablative?
Age cutoff between
RIC and myeloablative?
And myeloablative.
So I think there is nothing written in a protocolized way about that. But once you start looking at patients beyond 50, we will look at them very closely whether we are going to really give them ablative transplant. Even when we go to a reduced intensity transplant, it's going to be probably a flu mel that we would like to offer these patients at all. Only when we are taking those patients who are more than 65 and going for a transplant, we'd probably start looking at really reduced intensity conditioning for transplant.
Any other questions?
I would just say about the reduced intensity. I mean, what, Johns Hopkins is using is a completely non-myeloablative approach, whereas everything else is, myeloablative to a certain degree.
Agreed, yeah.
It might be less toxic, but we are all doing myeloablatives in one way or the other. Even flu mel is myeloablative.
Yeah, you look at the chimerism pattern recoveries in flu mel, they mimic what happens in ablative transplant. It's not the characteristic really reduced intensity where slowly over the period of months the chimerism improves. Flu mel, we can expect at day 30 to see a complete donor chimerism sitting there.
It's better to call them reduced toxicity.
Yeah, yeah.
So we've started using Flu Trio, and recently we did a 67-year-old doctor. He just sailed through transplant with Flu Trio. Sure. Thank you very much, Ashish. We'll now move to the next talk. I'll invite Dr. Oro. He's going to talk on myelofibrosis. I think Oro is well known to all of us, and he's a consultant in Canada.
Thank you, Viju. So it is always a pleasure to be back here. So what I'll be talking on the stem cell transplant in myelofibrosis, probably Ashish So subject is the commonest thing, what I can say. 85% of the patients in AML will require transplant if we'll remove 15% of the good risk. And in this disease, which is probably is considered as the most difficult disease in hematological malignancy, 10% of the patients will actually require transplant. We may say 50%, but finally the patients who will actually go for transplant will be 10% of the total patients whom you diagnose. I have nothing to disclose or declare. So myelofibrosis, it is a heterogeneous group of disorders. So survival ranging from 16 months to over 15 years. Stem cell transplant or a bone marrow transplant is the only curative modality at present. However, transplant is associated with a significant morbidity and mortality. Mainly depends on the patient and the disease-specific factor. Patient selection probably for this disease is the extremely critical to give the maximal benefit versus risk balance. Most of the outcome data are retrospective, and so far, there is no prospective transplant versus non-transplant study in myelofibrosis, and that is definitely is needed for future. So this is the CIBMTR data set, which shows that when the ruxolitinib came in and the FDA approval in 2011, and then it is the EMA approval, what is happening to the transplant numbers? It doesn't seem to be that the transplant numbers are really coming down. The age is definitely, the median age is gradually increasing because as all of us know that myelofibrosis is a disease, it happens in the older age. And most of the centers are still using reduced intensity / reduced toxicity, what I can say, because the patients are old, a lot of comorbidities, marrow is fibrotic. It is not only in the marrow, also the fibrosis happens in the other organs in this disease, so they don't tolerate the myeloablative regimens that well. So this is the trial which actually told us that who are the patients in the myelofibrosis needs to go for transplant. So when we look at a different scoring system, starting from the IPSS, then DIPS plus, and all others, so this is the trial which showed from Germans that those patients who are low risk or intermediate 1 risk, they do not get benefited by transplant. I don't have a pointer here, but that shows that in the upper part that they do not get benefited by transplant. Whereas if we look at the intermediate 2 or the high risk, definitely their survival with transplant is superior in comparison to non-transplant strategies. So this study took about 438 patients and compared between transplant 190 and the conventional 248 patients. Thank you. But what is important to remember that this study was done, and the caveats are, it was only primary myelofibrosis, no post-thrombocytemic or polycythemia vera. Age was less than equal to 65 years, and not a single patient in this cohort actually received JAK inhibitor. So can we extrapolate this data to the recent situation where probably most of the patients may receive JAK inhibitor before they come and see us? And then the decision tree in myelofibrosis is also very complex. One has to look at a patient factors, disease factor, and the transplant factor. On this arm is the transplant, and on this side is the JAK inhibitor. If someone is at advanced stage, poor performance status, prohibitive comorbidities, ideally they should go for a JAK inhibitor. Disease status wise, if someone has got a portal hypertension, then ideally they should go for a JAK inhibitor rather than the transplant. However, if that person has got a high risk of leukemic transformation, who has got a well-matched donor, then that person, if he is fit, then has to be taken for a stem cell transplant. So the decision tree is not that easy. One has to put all these factors and then decide that in which arm that person needs to go about. And to make the things complicated, at the recently identified multiple mutation profile, cytogenetics, which need to be definitely integrated into this decision tree to decide who can be benefited by transplant. And unfortunately, this is a disease which with too many assays also. Look at the assays here. IPSS, DIPS, DIPS plus, MIPS, MIPS plus, and GIPS. And I believe the most recent one is GIPS plus. So to identify the patient, what we identify clinically at the DIPS, then things are changing, and probably the transplant decision is going to change much more in future. And some centers are actually putting all these things into algorithm when they are taking the patient for transplant. And one of these is the MIP70, or a mutation-enhanced international prognostic scoring system for transplantation. What the MIP70 has told us that probably the patient who are still intermediate risk, which may be intermediate 2 in a DIPS category, whom we are taking for transplant before, but at present they are not indicated for transplant. So the only group of patients who will be going for transplant is that if they're having a high risk here in a MIPS or a very high risk score here in the MIPS plus, other group may not require transplant because they have put different mutations, and then looking at those mutation profile, looking at the adverse cytogenetics profile, then the risk category and those people who are needed to be taken for transplant is gradually changing. However, even if we say that it is a intermediate 2 or a high risk group of patients will be taken for transplant, what about some category which have not been identified or which have not been defined in this IPSS category? For example, a patient who remember that JAK inhibitor doesn't prevent the leukemic transformation. So if someone has got a persistent positive more than 2% peripheral blast in the peripheral blood, not only at one occasion with a progressive increase in the peripheral blood blast, then that person may be a candidate for a transplant. And then the triple negative group, definitely their outcome is poor. High risk mutation, if someone is showing positivity, particularly ASXL1, then that is the group of patient who needs to be taken for transplant. And then the next question comes as transplant when? Are we going to wait for the patient to progress to leukemia and then give some chemotherapy and then decide to go for transplant? This is the outcome from our center data. When the patients have progressed to leukemia, even if you take them for transplant, the outcome is not good. So one has to plan to take the patient for transplant before there is a leukemic transformation. And the same thing has been shown by the EBMT group, that your overall survival and the PFS significantly reduced for those cohort of patients in myelofibrosis who have actually progressed to AML, and then they are taken for transplant. What is the impact of mutations on the survival? The group who are triple negative, they do not do well. There have been high-risk mutations which have been found that it affects the outcome. So if someone is having a high-risk mutation, then there is all justification in taking or recommending this kind of patients into transplant, including those who are triple negative. Do we have the data that if someone has got high-risk mutation, transplant actually overcomes? Yes, so this is the data from the Mayo Clinic, which showed that the patients who have got high-risk mutation, and this is the non-transplant group, this is the transplant group, if you take them for transplant, then that high-risk mutation-related adverse prognostic factor can actually be taken care of, and the outcome can be better by taking them for allotransplant. So putting all these things together, so EBMT has its own recommendation, and recommendation-wise, all patients with the intermediate 2 and high-risk disease, considering IPSS, DIPS, and DIPS plus up to age of 70 should be considered candidates for transplant. In the intermediate 1 risk category, up to age 65, the patient can be considered for transplant if they have got a percentage of a blast which is more than 2% in the peripheral blood, transfusion-dependent anemia, or adverse cytogenetics. So this is the group of patients in a IPSS1 can be considered for transplant. Patients in the low-risk disease should not be considered for transplant, and they should be monitored alone. What happens in the molecular risk category? So EBMT recommendation is that if someone is a triple negative or if ASXL1 positive, they should be considered for allotransplant if a suitable candidate or a suitable donor is present. Sorry about the busy slide, but just next 2 slides, what I just want to show that the data on a myelofibrosis putting all transplants are not that many. Total number of patients in each of the trial varies between 150 to 200 maximum, but most of the trials are less than 100 patients. And if you put everything together, their 5-year overall survival is around 50 to 60%. And some of the trial, they put it as the 5-year overall survival is about 40 to 45%. In a reduced intensity conditioning, the 5-year overall survival is a bit better, but average, it is a 50% when you look at most of the trial data. So then if you look at a flu-bu and a flu-mel, and do you have a particular conditioning regimen to choose? So this is the comparison in myelofibrosis between a flu-bu and flu-mel. The number of patients are about 160. Progression-free survival was 52% in flu-mel versus 33% with the flu-bu, even if there is no overall survival difference. And this happened mainly because in the flu-bu arm, which is the red color arm here, the number of relapses were more in comparison to the flu male. So again, I'll come back that transplant when, particularly with the era of a JAK inhibitor. Can we take the patients upfront when someone is showing a clinical improvement or stable disease with a JAK inhibitor therapy, or delayed? So delay the transplant as much as possible if someone is showing a response with a JAK inhibitor and then take the patient for a transplant, or whenever there is a loss of response, or probably the timing is too late when the patient has progressed to leukemia and we know that the outcome is quite poor. So when we talk of a JAK inhibitors and the transplant, there have been advantages and disadvantages of the JAK inhibitor. The advantages are, when you use the JAK inhibitor pre-transplant, there is a reduction in the splenomegaly, control of constitutional symptoms, better performance status, improved weight, so that more number of patients may be fit to be taken for transplant. However, there are multiple disadvantages also. A patient may be continuing on a JAK inhibitor even if he is an appropriate transplant candidate, so there is always a risk of delaying a transplant just to get a feel that, okay, this person is doing well. We all know that if a patient is on JAK inhibitor, there is always a withdrawal effect, and some patients we may lose, unfortunately, because of a cytokine storm. Hematopoietic recovery has been shown in some studies that there is a delayed hematopoietic recovery with a JAK inhibitor. Possible infection, particularly HSV infection and the urinary tract infection, have been found to be high in those patients who are on JAK inhibitor. Reduction in the GVL effect, drug interaction, particularly with a cyclosporin and tacrolimus, along with a posaconazole when the patients have been on JAK inhibitor, and there have been evidence of a tumor lysis when the patients are on JAK inhibitor. Along with that, the JAK inhibitor, we also need to remember, these are non-curative, doesn't prevent leukemic transformation. Effectiveness on reversing fibrosis is doubtful. So JAK inhibitor may be there, which may help in the constitutional symptoms, recovery of the constitutional symptoms. It may help in the reduction of a splenomegaly, but that may not be the drug and which can tell us that, okay, this person can be taken for transplant or this person cannot be taken for transplant, because still there are a lot of issues with the JAK inhibitor which are not clear, and particularly it is not curative and it doesn't prevent the progression to leukemia. So this one is the JAK-ALLO study, which is a phase 2 trial, where 23 patients were enrolled and the flu male was the conditioning regimen. Unfortunately, this JAK-ALLO study was prematurely terminated in view of severe adverse event, and the severe adverse event included cardiogenic shock and the tumor lysis for those patients who were receiving JAK inhibitor and were taken for transplant. So then subsequently the retrospective studies have been done, and this is one of the larger trial considering about 100 patients who have received JAK inhibitor and then they underwent transplant. This is a multi-center trial, which showed that the overall survival, relapse, non-relapse mortality, neutrophil engraftment, acute or a chronic graft versus host disease, there is no difference if the patients have used JAK inhibitor prior to transplant. But the most important thing is, this group, they divided all the patients into 3 groups. So group A, who are doing very well with a JAK inhibitor, and JAK inhibitor is actually producing a clinical benefit. Group E, where the patients actually progress to acute leukemia while on JAK inhibitor. And group B, C, D are the combination of all remaining who are there, like somebody is showing a response to the splenomegaly is coming down, constitutional symptoms is improving. So when all these patients went for transplant, the transplant benefit was best seen in the group A patient who have shown a fantastic response to the JAK inhibitor before going for a transplant. So we know that the early transplant is better, but how early? That is always a question mark, and that is always controversial when we take a decision of taking someone for a transplant who is doing very well with a JAK inhibitor. This is a prospective phase 2 study taking about 28 patients. JAK inhibitors at least for 8 weeks, which has continued median 7 months, and it was tapered over 1 to 2 weeks pre-transplant. Patients used either MAC or a RIC. This one was presented in the last BMT tandem meeting. So 2-year overall survival was 89% in this group of patients who have used JAK inhibitor. And they compared to a closely matched historical control, and this historical control, their outcome or a survival was 54% who didn't receive a JAK inhibitor. So there is a signal, probably is there, that it may help in the survival, but a phase 3 randomized trial or at least a long-term follow-up of the trial is required, trying to see that whether there is a survival benefit. Then if there is a survival benefit, then using JAK inhibitor pre-transplant may be beneficial. So based on this, EBMT and the ELN recommendation was JAK inhibitor therapy, ruxolitinib or the others, is indicated in patients with symptomatic spleen or with constitutional symptoms. Important to remember that only these two indications, if somebody has got a splenomegaly or a constitutional symptoms, not for any other indication. The drug should be initiated at least 2 months before transplant and should be titrated to the maximum tolerated dose. But what is more important is the tapering of the dose has to be started at least 1 week before the conditioning regimen starts. So normally we started between 5 to 7 days prior to the conditioning regimen, and the last dose is given just 1 day before the conditioning regimen starts, because with this, actually the withdrawal effect is less, and the chance of any of the cytokine storm or what the initial JAK-allo study showed that the patient can have a cardiogenic shock, that can be prevented by continuing it almost near to the conditioning regimen. So what are the risk factors for the outcome after allo transplant? Consistently increasing age is bad, and the donor, when we have an unrelated donor or a mismatched donor, that is considered as a bad outcome in patients who are undergoing transplant in myelofibrosis. And this is from Dr. Kroger, showing that the age less than 55 years, age more than 55 years, overall survival is affected with a higher age. When we are looking at a donor status, consistently it has been shown that if someone doesn't have a match-related donor or a fully match unrelated donor, then a mismatch unrelated donor outcome is inferior in patients who undergo transplant in myelofibrosis. So this is the related donor and the mod arm, and this is the mismatch unrelated donor. And exactly this has been shown in multiple trials, showing that if you have got a mismatched donor, the outcome is not good in comparison to the fully matched or a match-related donor. Then another two things which are again a major issue in patients with myelofibrosis, which is not seen in other leukemias. One is a splenomegaly or a roll-up splenectomy. Second thing is the graft failure. So the splenectomy, in multiple trials, it has been shown that it improves engraftment. However, there is no trial which has shown that by doing a splenectomy prior to transplant, it affects the graft failure. So the graft failure rate remains the same. So the question is, probably it may be the microenvironment which is affecting it, but the graft failure rate doesn't come down whenever we plan to take somebody for a splenectomy prior to transplant. Splenectomy doesn't affect survival, so accepting engraftment, which has been consistently shown, probably splenectomy is not that useful in taking for all patients who have got a big spleen prior to transplant. So it cannot be generalized as a recommendation that everyone needs to go for splenectomy. It needs to be decided case-by-case basis. It is more important because perioperative complications can go up to 25%, and which can include both bleeding and thrombosis. So this is the group of patients who have been divided into a low risk and high risk, considering that if the spleen size is more than 22 centimeter, transfusion more than 20, or donor other than HLA identical sibling. So the low risk is 0 to 1 and high risk is 2 or more risk factor. So based on this recommendation, EBMT recommends that anybody who has got a more than 22 centimeter spleen pre-transplant, it will be better to go for a splenectomy prior to taking the patient for transplant. Second one is the graft failure, because in other diseases, when we are talking of a graft failure rate of about 4 to 5%, in different publications in myelofibrosis, it ranges from 5 to 25%. Not only that, this is also another disease where not only the primary graft failure, also secondary graft failure is quite common. Splenectomy doesn't affect the graft failure rate. PBSC is preferred for better engraftment. However, there is no prospective trial comparing PBSC versus bone marrow in this group of patients. And the graft failure is considered maybe some role of cytokine or may be dependent on the bone marrow microenvironment. So based on this, EBMT recommendation was that individual transplant-specific prognostic markers should be assessed, And particularly, these are the high risk what can be considered when the patient is being taken for transplant: spleen more than 22 centimeter, 20 transfusion or more than 20 transfusion, mismatched donor, comorbidity index more than 3, or portal hypertension. Decision regarding pre-transplant splenectomy should be done by case-by-case basis. It cannot be generalized. The important thing is that the splenomegaly sometimes can persist 1 year post-transplant. So one shouldn't be much more worried that if by 3 months or 6 months spleen has disappeared, because it takes long time for the fibrosis to get better and for the splenomegaly to get resolved. Are we improving? Yes, so if we look at the cohort of the patients who have been transplanted from 2010 to 2000 to 2010 and 2011 to 2014, definitely survival is improving. The relapse rate is getting better, and the transplant-related mortality is improving. So this may be better use of more of a rectransplant, better choosing the appropriate donor, and probably modifying the transplant protocol or a conditioning regimen and the GVHD protocol in a much better way, what is happening recently. Can one monitor the JAK status post-transplant and consider giving DLI? Very small study, but looking at a preemptive DLI versus salvage DLI, when the preemptive DLI has been done looking at a JAK status, people can achieve about 100% of the CR, whereas salvage DLI is about 44%, and the acute graft versus host disease was 0% versus 22%. Still, a research question cannot be recommended to be followed for all patients, but there is a possibility of considering preemptive DLI in some patients. Again, a research question. We have to wait for the phase 3 trial data to see how the effect is. But in the initial phase 2 trial data, and there are multi-center data, ruxolitinib in corticosteroid refractory graft versus host disease has been found to be quite effective. Steroid refractory acute graft versus host disease, the response rate is 81.5%. In chronic graft versus host disease, the response rate is 85.4%. As you all are aware, the phase 3 randomized trial is on. We have definitely eagerly waiting to see what is the phase 3 randomized trial data. So then in transplant decision, when we take in a myelofibrosis in the pre-transplant, JAK inhibitor helps in the reduction of the splenomegaly, control of a constitutional symptoms. One has to look at a reduction of the iron level, splenectomy in specific cases who have got huge spleen and who have also failed JAK inhibitor. When we are taking a transplant decision for during the transplantation, appropriate donor selection, ideally a match related, and if match related is not there, then 10 by 10 unrelated donor. Look for specific comorbidity like portal hypertension. We ask for all patients to go for an endoscopy and to rule out that portal hypertension before taking this patient for transplant. Reduced intensity conditioning regimen is probably the better way to go about looking at their comorbidities, age. But however, if a patient is young age with a very good performance status, definitely myeloablative can be tried, and that may actually help in controlling the fibrosis of the bone marrow. JAK inhibitor, if the patient is receiving, is recommended to be tapered 5 to 7 days prior to starting transplant and stop just before starting the conditioning regimen. Post-transplant, monitoring of the MRD, reduction in the immunosuppression and DLI if loss of chimerism. So to conclude, transplant is an appropriate option for selected patient with myelofibrosis, particularly in the intermediate 2 and high-risk disease. Intermediate 1 with specific clinical scenario like a transfusion dependency, thrombocytopenia, persistent and progressive increase in the blast, or unfavorable cytogenetics. Selection of patients should be individualized based on patient wishes and other patient disease and transplant-related factor. That is the reason why I say that taking a decision for a transplant, decision for a myelofibrosis is the most difficult thing. When used in the setting of transplant, JAK inhibitor therapy should be continued near to the start of conditioning therapy. And continued enrollment in the prospective studies is required to identify the optimal time of transplant in myelofibrosis patient. As I mentioned, still there is no randomized trial between a transplant and a non-transplant arm. Thank you very much.
Thank you, Oro. Any questions from the audience? John.
Thank you, Aro. That was a great presentation. You probably prepared your slides well in advance. So did you have any thoughts on the very recent New England Journal paper that came out where they were using this individualized risk prediction in myelofibrosis using a combination of a 70 gene panel with clinical variables, karyotype, et cetera. Because one of the things that struck me when I read that paper was the finding that myelofibrosis, whether it's primary or secondary, had no impact on the prognostication in their model, which is contrary to what I've always believed, which, as you said, was primary myelofibrosis may be very different from burnt out PV. So did you have thoughts as to where that would go? They had this whole website where you can go and you can plug in all the variables and spit out an individual risk profile for your individual patient.
Thank you, John. I didn't put that paper and what was the outcome in that paper, which has just came up in the NEJM. So we are looking at at our center also, we are looking at, through the agile technique, all the genetic markers. And when we are looking at all genetic markers, we are actually taking the patient based on the genetic markers who are showing high-risk mutation positive. So when we look at a MIP70, for that reason, about 6 months back, we are only going by the dips. Now for last 6 months, we are going by the MIP70, and we are looking at how many high-risk cytogenetics high-risk mutation profile is there. And if the cytogenetics is there, and we are actually taking our decision based on the mutation profile. So I think that will probably be this way to go about, but can it be generalized? Can all center will have the access to that molecular profile? That will be a bit of a challenge, but I agree that may be the way to go about slowly, which is coming up in the AML, which is coming up in the myelofibrosis. And it is really interesting to see that even before the ELN recommendation came up, myelofibrosis is probably the first disease where EBMT put a recommendation looking at these 3 high-risk mutation positive, someone can recommend the patient to go for transplant.
Neeraj.
Excellent presentation, sir. So my question is regarding, a patient with IPSS intermediate 2. You can have a patient with an intermediate 2 if the hemoglobin is less than 10. So even if it's 9.7, 9.6, and stable hemoglobin with more than 1% blast in the peripheral blood, absolutely asymptomatic, young patient with large spleen, would you still recommend a transplant in such patient upfront, or would you wait, or would you give a JAK inhibitor in that case?
I'll probably modify rather than the IPSS at the diagnosis, I'll probably look at a DIPS, because as you know, that each patient in a myelofibrosis, they behave differently. The peripheral blood blast in the IPSS, what you are seeing today, it is the 1%. If you follow up that person, probably after 2 weeks, that person may be showing 5% blast in the peripheral blood. After 1 month, you see that person, they may be showing 1% in the peripheral blood. So the decision becomes extremely challenging. That is the reason why the blast percentage is not considered as only one category. They put 2, what I can say, prefix to that, persistent and progressive. So that one has to look at a profile of that patient in the few months timeline, how he is going. Talking about your patient who has got a huge spleen, even if that person has got a hemoglobin which is a 9.7, I would probably say some amount of that low hemoglobin may be part of a hypersplenism. Because if that person is young and is absolutely good performance status, accepting a hemoglobin of a 9.7, I would not push him for transplant. With a splenomegaly, I would definitely see that how his response to the JAK inhibitor. If he's showing a very good response to the JAK inhibitor, he can actually be continued on the JAK inhibitor with a very close follow-up, trying to see that is there a possibility that at some point of time his peripheral blood blast is increasing. And these are the kind of patient who may be benefited by looking their genetic profile. Like exactly your patient, if we have got only the JAK inhibitor, he's showing a response, but that person is a ASXL1 positive, then my threshold for taking the patient for a transplant will be low, rather than waiting for me to see that when that patient is progressing to leukemia.
Thank you for the nice presentation. So my question is on primary autoimmune myelofibrosis, sir. In primary autoimmune myelofibrosis, if the patient is progressing despite of immunosuppressants, if the fibrosis is progressing, is there any role for transplant?
Okay, I probably knowingly didn't want to review the whole myelofibrosis. I thought that I'll probably speak only about the transplant. But if somebody is a primary autoimmune myelofibrosis and with an immune suppressive agent, particularly either with a cyclosporin or other immunosuppressive agent, the person is not doing well and there is no clinical response, definitely there is a role of taking the patient for transplant.
Thank you, sir.
Oh, nice talk. Thank you. One comment and two questions. One, we've also seen down that with the easy availability of molecular information on patients with myelofibrosis, the referrals for transplants for myelofibrosis has significantly gone up. So, and I think that's what you were reflecting in your CIBMT. It's probably not just ruxolitinib, it's the easy availability that everyone's doing this molecular profiling. So first question I had was, how low would you go in your reduced intensity? Or do you have a point at which you say, doing a transplant with this conditioning is perhaps not worthwhile in myelofibrosis?
Okay. So first thing is that what you are telling, the total number of patients with a myelofibrosis has increased. I totally agree that maybe we are seeing more at PMH because it is a referral center and we have a separate myelofibrosis program. But previously, I can tell you that in the last 1.5 to 2 years, myelofibrosis is currently our third largest indication for transplant. First one is AML, next one is MDS, third one is myeloproliferative disease, or particularly myelofibrosis. ALL has significantly gone down, other lymphomas have significantly gone down. So definitely we are seeing that number which is increasing, and my assumption is that it will go on increasing, one. Second thing is about the conditioning regimen. We use most of the patients flu-bu, and we would still probably, depending on if their performance status is good, I think 2 days of bu they should be able to tolerate, and we use flu-bu 2. We give 200 centigrade TBI to most of the patient. So most of our RIC is the flu-bu 2 and 200 centigrade TBI.
Last question if I could. So I'm just going to take up on John's point about the mutational profiling. So if you get 2 patients in your clinic, does mutation profile always supersede the biology of a disease? So let's say you've got a primary myelofibrosis who's got an abnormal mutation profile, clearly a candidate for transplant. You got a post-PRV myelofibrosis who's been referred for a transplant, let's say a 50-year-old gentleman with a spleen getting cytopenic, but does not have a mutational abnormality there apart from a JAK2. Would the biology of the disease be a consideration for transplant, or it's always the mutational profile?
It is always clinical. It is, I would still consider going ahead with that patient with a clinically when there is an indication to go for transplant. I think the molecular profile thing is evolving. We have to probably wait for mature data. But how the molecular profile will help us is that how frequently you are going to follow up on that patient. If someone is a high-risk mutation positive versus someone is a low-risk mutation or no mutation positive, I would probably see that patients more frequently every 2 to 3 months' time, and a little bit change in the peripheral blood blast or a drop in the hemoglobin platelet count maybe have more significant rather than someone who doesn't have a high-risk profile. So that one will mainly tell us that how we will decide that what is, because we don't want them to progress towards a leukemia and then plan to go for transplant.
Abhijit?
Or is there still the role of thalidomide prednisolone in low-risk myelofibrosis?
In our center, mostly they will use the JAK inhibitor. If it is required, they will use the JAK inhibitor along with the prednisone whenever it is required. But thalidomide, it is not that much used, the immunomodulator drug. Even the role of a hydroxyurea, if you look at, it is only useful for those myelofibrosis who are showing a proliferative type of myelofibrosis, rather than where the WBC count is not high, hydroxyurea may not be helpful. So, but mostly it will be JAK inhibitor or some other trial where the low-risk patient can be enrolled to.
If it is JAK negative, then you use thalidomide or nothing like that?
No.
I would say excellent summarizing of the whole topic, but I would like to hear from Dr. Fuchs about what is your experience on haplotransplants in myelofibrosis? That's one. And second, which we have seen, I don't know, whether this is something, because we have shared notes with it worldwide, that patients with myelofibrosis, even if you do a successful transplant, they can, especially when they are advanced and in leukemic transformation, they can relapse later with extramedullary leukemia. because of the myelofibrosis and because they have transformed into leukemia, they seed these cells at obscure sites and they can have a very late relapse with extramedullary leukemia. And the second point is, we have not done splenectomies, and I know that you have taken this data from Bacigalupo's paper of 22 centimeter. Whenever I see such data, all I would like to say is there is no magical figure as 22 or 21. What you mean is a big spleen. 22 versus 21 versus 23 doesn't have any significance. You mean a big spleen. 20 transfusions versus 19 versus 21 doesn't mean anything. You mean a lot of transfusions. So let's be clear about this. And doing a splenic irradiation peri-conditioning is something we have found very useful in big spleen without going for a splenectomy. I'm talking largely of haplotransplants in this condition. And we have had successful engraftment using this protocol, but I would love to hear from you.
Well, we don't use splenic irradiation. My personal experience has been miserable. I think our graft failure rate is probably about 40 or 50% for patients with myelofibrosis. It's with our non-myeloablative regimen, and we're trying to adjust our regimen to improve engraftment by going to 400 centigrade of total body irradiation using peripheral blood. But when we use peripheral blood, then we have cytokine release syndrome, which for these patients, for whatever reason, tends to be more morbid and less well tolerated. So it hasn't been good, and we don't do many.
Or just a clinical question. You have a patient with myelofibrosis who is not responding to ruxolitinib, massive splenomegaly, otherwise he's stable. How do you manage? Is transplant indicated in that condition? How do you manage the splenomegaly? He has got a massive splenomegaly, but not responding at all to ruxolitinib. So ruxolitinib, refractory splenomegaly, otherwise doesn't fit into intermediate 2 or whatever.
I think that is a kind of patient who would definitely need splenectomy. Because this one is a high-risk patient where you have tried other drugs, you have tried even a JAK inhibitor, and the JAK inhibitor has not been able to control the spleen size. So those are the group of patients who will be really high-risk patient, and there, if you are planning to take the patient for a transplant, definitely splenectomy will be required. About a splenic irradiation, actually, if you look at a EBMT guideline, they do not recommend splenic irradiation, because either a patient will require a splenectomy and then plan to be taken before going for a transplant. And why that number 22 centimeter or a 20 centimeter, 20 transfusion has come? Because our leukemia program has got 12 staffs. When there are 12 staffs, there has to be a consistency. Otherwise, each person will be doing different thing. And this is the only publication which is in the literature. They have at least put a particular number, and that number has been emphasized by, I think there are about 13 experts in that EBMT group, and that EBMT group recommended that 22 centimeter. And that is the main reason is that why we plan to follow that. But I can totally agree with you, because it is just a number, but probably it will be difficult to say that from where that number came.
My question was, is the patient candidate for a transplant?
Yeah.
Okay, thank you very much, Oro.
Thank you
for the. Now we'll move on to the next talk. Dr. Ephraim Fuchs is going to talk on haploidentical transplant and how to choose a donor. Now, when we had sibling transplants, we had only one donor, maybe two sometimes. When it came to unrelated, we had some more donors. Now with haploidentical, we have lots of donors, and so you need to choose the right one. Over to you, Dr. Fuchs.
Thank you very much, Dr. George. I'd like to thank you for inviting me to this conference. My first time to India. It's a beautiful country with wonderful people. So I have a lot of slides, so I'll just go right into it. And I thought I would talk a little bit more globally about the issue of donor selection, not just about among potential haploidentical donors, but also comparing haploidentical to matched unrelated, haploidentical to matched sibling. But and this is basically the Hopkins experience with non-myeloablative haploidentical transplants and post-transplantation cyclophosphamide. But in general, we prefer to use related donors over unrelated donors. For one reason, there's a faster time to transplantation, so there's fewer patients relapsing as you're trying to identify a donor. And there's also, you have a greater control over the graft and the potential for donor lymphocyte infusion. Sometimes we'll get grafts from overseas with poor stem cell contents that they've degraded after long shipment times, and we don't have to worry about that with haploidentical donors. And we also prefer to use younger donors over older donors, and our cut point is age 40. You know, after the age of 50, you begin to see a higher incidence of clonal hematopoietic abnormalities. There's also better grafts from younger donors. And then among related donors, we do not prioritize on the degree of HLA mismatch, and that includes, you know, match-related versus match sibling versus haploidentical. So our algorithm overall for selecting haploidentical donors, there are really only two absolute requirements, and then there's just sort of a list of preferences. Absolute requirements is that the donor must be medically and psychologically fit to donate, and that there should not be any anti-donor HLA-specific antibodies that are at or above the level of a positive complement-dependent cytotoxicity cross-match, because that portends a very high risk of graft failure. And then our hierarchy of preferences for haploidentical donors is that we prefer donors less than 40 years of age. We prefer to avoid major ABO incompatibilities. We prefer to avoid CMV incompatibilities. And then, of course, for non-malignant diseases, we want to minimize the mismatching in the host versus graft direction to reduce the risk of graft rejection. So some of the topics I'm going to cover in this talk will be related versus unrelated donors, matched SIBs versus haplos, the issue of age and haplo donor selection, other biologic factors in haplo donor selection, and then I'll close on talking about the management of donor-specific anti-HLA antibodies. So talking about, addressing quickly the issue of haplo versus matched unrelated. So my hypothesis would be is that if you can get equivalent results with haploidentical donors as compared with matched unrelated donors, then there's no reason to have to even search for an unrelated donor as long as you have an available haploidentical related donor. And so to address this, these are some registry studies that were done. So Stefan Chure at MD Anderson had a registry study performed looking at haplo plus post-transplant cyclophosphamide versus matched unrelated donors in patients with acute myeloid leukemia. These are the results from the non-ablative transplants. And as you can see, there is a slightly higher, there's a lower non-relapse mortality with haplos, but a slightly higher relapse incidence. But overall and event-free survival are practically overlapping. So the outcomes for haplos are just as good as for matched unrelated donors. And I should say that's with a lower incidence of chronic graft versus host disease in the haplos. So then there was a study by Kanate et al. Looking at haplos versus matched unrelateds for lymphoma. And as you can see, there is less acute and chronic graft versus host disease with haploidentical donors. Non-relapse mortality is fairly low. Relapse rate is not significantly higher compared to unrelated donor without ATG. And overall and progression-free survival with haploidentical is comparable to unrelated donors without ATG. So again, what we're seeing is compared to transplants from 10 out of 10 matched unrelated donors, at least these registry retrospective analyses, haploid transplants with post-transplant cyclophosphamide produces equivalent outcomes with less chronic graft versus host disease. So I would say that the only reason to search for an unrelated donor is if a haplo or match-related sibling less than 40 years of age is not available, and I'll be discussing the age issue a little bit later. So let's talk about matched siblings versus haploidentical donors, because Tara Robinson, a fellow at Hopkins, and I proposed a study with the CIBMTR and also the EBMT to compare the outcomes of transplants from matched siblings versus haplo siblings, and that's largely in patients aged 18 to 54. And also a second comparison, which is matched sibling transplants versus transplants from the children of the patient. And that analysis was confined to patients aged 55 to 76, because that's where most of the offspring transplants are being done. So the study population, again, separate analyses for patients aged 18 to 54, where most of the haplotransplants were from siblings, and we compared them to HLA matched sibling transplants. And then patients aged 55 to 76, we compared matched sibs versus offspring, and you can see the numbers. And we did analyses by Cox regression, but we also did matched pair analyses, where we were matching the patients for age, disease, and disease risk index. So looking at the younger group, 18 to 54, looking at haplo-sibling transplants versus matched sibling transplants, you can see that graft failure is effectively no different between haplo-siblings and matched siblings. When you look at acute and chronic graft versus host disease, there's no significant difference in acute GVHD between haplo-siblings and post-transplant cyclophosphamide versus matched sibling transplants. There's a significantly lower incidence of chronic GVHD with haplo-siblings compared to matched siblings. Relapse and non-relapse mortality were not significantly different, and overall and event-free survival were also, again, practically superimposable. And if we look at the hazard ratios and multivariable analysis, we see that there was less chronic graft versus host disease with haploidentical in both the regression analysis as well as the matched pair analysis, but all of the other results, GVHD, non-relapse mortality, acute GVHD, non-relapse mortality, relapse, overall and progression-free survival were not significantly different. So now if we move to the 55 to 76-year-old group, comparing matched siblings versus offspring of the patient, and I should say, when we planned this out, I fully expected that the offspring would do better than the matched siblings. So I'm kind of announcing, I guess the result coming up. Anyway, but one thing that we can see already is that there was a much higher or a significantly higher graft failure rate with offspring transplants compared to matched sibling transplants. So, and these are highly significant results. When you look at graft versus host disease, however, the offspring or the haploidentical, offspring transplants had significantly lower acute and chronic graft versus host disease. When we look at relapse and non-relapse mortality, significantly higher relapse, significantly higher non-relapse mortality compared to matched sibling transplants. And then there were significant differences in favor of matched sibling transplants, with offspring transplants doing worse for both overall and leukemia-free survival. And then in the regression and matched pair analyses, we see lower GVHD with offspring transplants, but the non-relapse mortality, relapse, overall survival, and event-free survival were all in favor of the matched sibling transplants. So, to conclude, for patients aged 18 to 54, it appears that haploidentical siblings do just as well as matched sibling transplants with even less chronic graft versus host disease. And I would interpret from that post-transplantation cyclophosphamide has nullified the detrimental effect of mismatch on outcome for this age group. However, for patients aged 55 to 76, haplo-offspring transplants are associated, this is a little bit of a typo. For patients aged 55 to 76, matched siblings do better than haplo-offspring because of the higher graft failure rate with the haplo-offspring. And so therefore, post-transplantation cyclophosphamide does not nullify the detrimental effect of mismatching on graft rejection. So bottom line is, matched siblings, remain the donor of choice really for both age groups, because the results are not better with either age group with haplos, and they're worse in the older age group. So since HLA matched siblings are not inferior to either haplo siblings or haplo offsprings, the HLA typing should commence with the siblings to find an HLA matched sibling, and only if you don't have an HLA matched sibling would you look for a haploidentical donor. It might turn out that you find a haploidentical donor just when you're typing the siblings. One thing that we're beginning to do is we're beginning to get complete blood counts on our potential donors even before we do the typing, because we will knock out potential donors just on the basis of abnormal blood counts, and that's a much cheaper test than the HLA typing. So then the next question is, what about haplo siblings versus haplo offspring? Or what is the effect of the age of the donor on the outcome of haploidentical transplants? So this has certainly been studied in the context of unrelated donor transplants, or matched unrelated donor transplants, and this is from Coleman et al., an analysis of results from NMDP, and what you can clearly see is that the younger donors produce better outcomes, age 18 to 32, 33 to 50, and greater than 50. So in unrelated donor transplants, certainly younger donors are better. Well, what about haplotransplants? Well, this is a kind of a difficult question to answer because donor age is highly confounded with the relationship of the donor and the recipient. So for instance, if you look at donor ages less than 30, they're largely donating either to their siblings or to their parents, and the parents are usually the younger parents, right? If you look at age 30 to 45, you get a smattering of transplants to children, sibling transplants, or transplants into parents, the older parents. And then above the ages of 45, it's mostly where the donor, when the donor is greater than 45 years old, most of the recipients are either children or siblings. And so it turns out that it's this middle group that has the oldest recipient age, but it is a significant difference between these three age groups of donors. And so what we find is that, the younger donors have better graft qualities, both in the nucleated cell count, although for some reason this doesn't look like much of a difference, it does come out as significant. They have higher CD34 counts as well as higher CD3 counts, so you just get better grafts from younger donors. And when you look at non-relapse mortality and relapse, you see that with younger donors, we have significantly lower non-relapse mortality, but the relapse is effectively superimposed between the different donor age groups. But and when you look at graft versus host disease, you also see less acute graft versus host disease with younger donors, even despite the higher T cell counts in these grafts. There was also significantly less severe graft versus host disease. There was a lower chronic graft versus host disease, but that wasn't significant. And again, with older donors, because of the poor graft quality, there's a higher incidence of graft failure, although it wasn't significant. So when we look at overall survival, it approaches significance that the youngest donor age group had the best outcomes compared to 30 to 44 donors aged 30 to 44 or greater than 45. So just to conclude this section, younger donors appear to be associated with better outcomes overall, and this was found to be irrespective of the patient age and the disease risk index. The reasons for the better outcomes are multifactorial, with statistically less severe graft versus host disease, lower non-relapse mortality, and less graft failure, although that was not statistically significant. So these results have led us to incorporate the age of the donor formally into our donor choice algorithm. What about certain biologic factors that could potentially impact donor selection? So obviously the major biologic factor that we think about is the degree of HLA mismatch. So the question is, with post-transplant cyclophosphamide, has that had effects on graft versus host disease and survival? And so this was one of our earliest analyses, I think about 185 donor recipient pairs. And we looked at the cumulative incidence of acute graft versus host disease just based on the degree of mismatch in the graft versus host direction. And we divided it into two groups, one group with 0 to 2 antigen mismatches in the graft versus host direction versus 3 to 4 mismatches in the graft versus host direction. And as you can see, there's no significant difference in the cumulative incidence of acute graft versus host disease. Interestingly, however, as you increase the degree of mismatch, there's a trend, or actually a significant trend, towards improved outcome. So in other words, more mismatching improves outcome, and the hazard ratio is 0.8, so which means that for every increment of mismatch between donor and recipient, there's a 20% reduction in the risk of an event, either death or relapse. So, and where is that reduction in risk coming from? Well, it appears to be coming from class 2 mismatching, specifically HLA-DRB1 mismatching. Because if we look at patients without a mismatch, that's blue, and this is at HLA-DRB1, and we're looking in the graft versus host direction here. The patients that actually had the mismatch at DRB1 did better than patients that did not have a mismatch at HLA-DRB1, and that's significant both for overall and event-free survival. Sort of as a control, we looked at HLA-DPB1, and there was no significant benefit of HLA-DPB1 mismatching. So class 2 mismatching in the graft versus host direction appears to improve overall and event-free survival. And we also see that with DRB1 mismatching, even though we do have increased graft versus host disease, we do not see a significant effect on non-relapse mortality. There does appear to be a decreased risk of relapse with this mismatching at DRB1 accompanying the increased GVHD, but it's not significant. Also, we looked a while ago at the effect of KIR ligand incompatibility. We saw no benefit of KIR ligand incompatibility, but we did see a benefit of using donors with a KIR, at least one KIR B haplotype. So this is BX, so that would be either BA or BB versus AA haplotype donors. And there was a significant benefit of having the KIR B haplotype, which has more activating KIR receptors compared to the A haplotype. So to conclude, in terms of donor selection among haplodonors or overall, HLA-matched SIBs remain the best donors. Haplo, I would prefer over unrelated donors. And then among potential haplos, obviously we need to avoid DSA, which I'm going to talk about, donor-specific antibodies. We desensitize when necessary. When we have a choice of haplo donors, we will choose the youngest suitable donor. We avoid ABO and CMV incompatibility. And we can, consider choosing donors based upon class 2 mismatching, especially if we have poor risk diseases with high risk of relapse, or also donors with a KIR B haplotype. All right, so I'm going to close by talking a little bit about management of donor-specific anti-HLA antibodies. So Stefan Chure published, a number of articles showing that number one, the presence of anti-donor HLA antibodies predicts for graft failure. And if you look at patients with anti-donor antibodies with a mean fluorescence intensity greater than 5,000, there were 7 patients out of 11 had graft failure, versus less than 5,000, there were no graft failures, and this was significant. And of course, graft failure is a bad thing. It portends worse survival. So if you look at patients that had graft failure, all of them are dead by 24 months versus those that did not experience graft failure. So that was a significant difference. So how do we do our antibody assessment at Hopkins, and how do we manage these patients? We use the solid phase immunoassay from Luminex, which can screen for antibody specificity as well as the level of antibody. It also appears to be more sensitive than the cell-based assays, such as the flow cytometric cross-match or the complement cytotoxicity cross-match assay. There are different formats for the Luminex assay. On the left, there are the pooled antigen beads where you have either class 1 or class 2 molecules on the same bead from several different individuals. There is the single phenotype beads, or the phenotype beads that have HLA molecules from single individuals. And then obviously the most specific would be the single antigen beads where you just have a recombinant product of one HLA allele. So what we do is we initially evaluate using the screening and the phenotype beads, looking for the presence of any antibodies. Are they directed against class 1 or class 2? And if we do have anti-donor HLA antibodies, we'll go on and look at the fine specificity using the single antigen beads. If the patient appears to be unsensitized, like they have negative tests on periodic screening, we will reassess, within 30 days of transplant to make sure that they didn't have a sensitizing event in the middle of our evaluations. And for sensitized patients, we'll screen them monthly before transplantation to see what's happening with their antibody. So it turns out that there is a correlation between the Luminex assays and the flow cytometric or complement-dependent cytotoxicity cross-match assays. So using the phenotype beads, you know, an MFI of greater than 5,000 would correspond to a positive flow cytometric cross-match, and an MFI greater than 10,000 would correspond to a positive complement-dependent cytotoxicity cross-match. With the single antigen beads, you need an MFI of greater than 10,000 to achieve a flow cytometric cross-match positive result. And then, you know, so using the Luminex technology, we've looked at 296 patients undergoing haploidentical transplants, and it turns out that the incidence of positive anti-donor HLA antibody is overall is about 14.5%, but it's most commonly found in Paris females, as you can see in the second to bottom line. The incidence was 27 out of 63, or 42.9%. So DSA is a significant problem in women who have had children. It's also a more significant problem in haploidentical transplant because a higher percentage of recipients of haploidentical transplants will have moderate to strong antibodies against the donor. About 68% that are DSA positive have moderate to strong antibodies versus only 46.7 in mismatch unrelated donor transplants. So our desensitization regimen will begin 1 to 2 weeks before the conditioning regimen. And I should say that we do desensitization in people generally that have a positive, that would have an assay corresponding to a positive flow cytometric cross-match. We do not desensitize patients that have strong antibodies at the level of a positive complement-dependent cross-match. So we would begin 1 to 2 weeks before the conditioning. We start with plasma exchange, alternate day, single volume with, combined with intravenous immunoglobulin at 100 milligrams per kilogram per treatment. We also give tacrolimus, a milligram IV daily through day -1 of transplant, and mycophenolate mofetil also through day -1 of transplant. On day -1, we'll evaluate for evidence of rebound of the DSA, and if they have a rebound of their antibody, we would then perform another plasmapheresis and IVIG on day +1 after transplant, and potentially on day +2, depending on the antibody level. So, you know, the number of plasma exchange and IVIG treatments before transplant depends on the level of the antibody. So if it's very low level DSA, not with a flow cytometric cross-match positivity, we would not give any plasmapheresis before transplant. We might do one, after day -1, depending on the level on day -1. But otherwise, we would do plasmapheresis and IVIG for patients that are positive flow cross-match. And again, so this is the treatment schema, the alternative day plasmapheresis. Prior to the initiation of conditioning, we check again on day -1, and on day +1, less than 10% of patients will end up with getting a single volume plasma exchange on day +1. And just to update our data from what's been published, we've had 40 patients that have undergone plasma exchange, IVIG, tacrolimus, and mycophenolate mofetil. We've successfully desensitized 39 out of our 40 patients. The one patient that we could not desensitize, sorry, my time, is this the Grim Reaper? That's, okay, oh, sorry. So we were successful in reducing DSA below the levels of a flow cytometric cross-match in 39 out of 40. We could not desensitize the one with the positive CDC assay, which is why we don't do them anymore. And then 38 patients underwent transplant with no graft failures. We had full engraftment in 29 out of the 38, mixed chimerism in 7 out of the 38, and 2 out of the 38 had only host T cells with some degree of myeloid chimerism. and then finally, what if the patient is highly sensitized to all potential donors in the immediate family? In that situation, we would consider doing transplants from second-degree relatives, such as cousins, nieces, or nephews, or we would do a partially mismatched unrelated donor transplant with post-transplant cyclophosphamide. This is from a publication last year from Yvette Kassamon at Hopkins and colleagues. Basically, this is the regimen. We substitute sirolimus for tacrolimus. And we've had very good results with mismatched unrelated donor transplants with low GVHD and good survival. So just to summarize, for patients aged 18 to 54, we would consider matched siblings and haplos to be equivalent, but both we would prefer over matched unrelated donors. 55 to 76, we prefer matched siblings over haplos over MUDs. Among the haplo donors, we would avoid a strong anti-donor HLA antibody. We would prefer younger donors. We can desensitize if we need to in patients with positive flow cytometric cross-match to enable transplantation. But if the antibody is so high that it would give you a positive complement-dependent test, we would look for a different donor, such as a second-degree related donor or a mismatched unrelated donor. And I would like to thank my colleagues, and I'm happy to take questions. Thank you.
The session is open for questions. Let me start with two questions. One is, you talked about the age, and you had mentioned the age of 40 years for the donor. But in your graphs, you had a cutoff of 30.
Right.
30 years, 30 to 50. So where did that 40 come from?
So we did do an analysis of survival, like sort of as a continuous function of age. And we did find that once you hit 40, the survival starts declining. So that was our cutoff point. Now, for donors that are 50 or above, if they have abnormal white cell count or platelet count, or if they're above the age of 50, we do next generation sequencing on all of them to look for mutations in clonal hematopoiesis to avoid transplanting or generating donor-derived leukemias.
The other question was with regard to degree of HLA mismatch. Now, you showed that more mismatches were better. Now, is that true for both malignant disease and non-malignant disease?
That was just for malignant disease.
So do we have any data on non-malignant disease? Does it matter?
So with non-malignant disease, I always assume that the more mismatches in the host versus graft direction, the higher risk of graft failure. I haven't put that to the test, but it just makes sense on the basis of the fact that there's always a higher graft failure rate with haplo compared to matched SIB. So I would assume that the more mismatches, the higher risk of graft failure. So I just, if I have, all other things being equal, I will choose less mismatching in non-malignant disorders, but specifically less mismatching in the host versus graft direction, because I just want the graft to take.
John.
Effie, how does this compute? So you're telling us that when you take donors of the same age, haplografts perform equivalently to a matched SIB. But when you take a young haplograft and an old matched SIB graft, then the old matched SIB is doing better than the young? I mean,
yes.
At what level does that make sense?
So it does not compute. Well, let me just say this. The comparisons that I did, the first set of comparisons had to do with matched SIBs versus haplo donors. Mm-hmm. And in that situation, an older matched SIB was better than a very young haplo donor, a child, right? The other comparison that was done that showed younger was better was solely within the haplo realm, right? But I'll say that I think that the matched SIB versus haplo comparison was done correctly because that was something that I thought of, and the other one was some colleagues of mine, which I think the problem there is the donor age is confounded with the donor-recipient relationship and with many other things, and I'm not sure I have a lot of faith in the results of that analysis. What I wanted to say is that really it's the unrelated donor transplant analysis, that Coleman did, that really shows that younger donors are better. because there you're just taking, random transplants, and it turns out that the recipients are all, well matched between groups, and the only difference is the donor age, and the younger donors gave you better outcomes. So to me, that just, that should carry over to haplo.
I might want to see another data set showing the same, the same finding that a younger haplo is
Yeah,
outperformed by
it needs to be done in a
76-year-old
different.
matched sibling.
Absolutely, it needs to be done differently.
And then the only other comment that I had here was in your comparison, when you're looking at matched unrelated versus haplo, really what you're looking at is haplo with PTCI versus a matched unrelated with TAC methotrexate. And as we know from BMT-CTN 1203, if you were, for instance, to use PTCY with a matched unrelated donor, you may end up in a different place. So that will end up needing to perhaps be a separate analysis, or at least a cross comparison with that arm in the study.
I agree with you 100%. The only way to do it, I think these comparisons of graft source, is to have the conditioning regimen be identical and change only the graft source. And you'll almost never see that. Frankly, I think that trying to compare haplo versus unrelated is problematic because of the time to find a donor differs between the two. So do you randomize up front, or do you only randomize when you are sure that you have both types of donors? So it's a real challenge.
So Oro and then Suparno.
Thank you. It was a fantastic presentation. So I have two questions. How young the donor has to be? Like suppose you have got a child who is 8 years versus an unrelated donor who is 25 years, who is 10 by 10. Would you still prefer a 8-year child and then ask the pediatrician to go and collect the stem cell? Or would you prefer a young, unrelated 25-year 10 by 10?
So, okay, you're asking if you have like an 80-year-old donor versus
8 year, 7 years or 8 years child is a haplo donor, and unrelated donor who is a 25 years.
Oh, 7 or 8-year-old?
Yeah.
Well, that's a consent issue as far as I'm concerned. So we try to confine our donors to like adults. So I don't know what's the age at which grafts start getting sour, but like we have the, it's sort of like, it was a little bit of an art, because like like we'll say, like you'll have a situation where you have one donor is 41 and is ABO compatible, and then you have another donor who's 39 who's ABO incompatible. And then we say, well, our cut point is 40, so we should take the 39-year-old. Well, we're not going to do that. It's only a 2-year difference, and we'll take the ABO compatible donor in that situation. But I'm not sure I understand your question. Maybe we can talk afterwards.
Sure. And my second question is, can any of this data be extrapolated to use when the peripheral blood stem cell as the stem cell source? Like, for example, you showed that if there is a mismatches or more, then there is a trend that outcome may be better, but that may be probably only using bone marrow as the stem cell source. Or a HLA-DR mismatch, that may be better, but that may be probably using only bone marrow as the stem cell source. Can you extrapolate that one to the PBSA, which most of the centers are probably doing haplo with a PBSA? Oh,
okay. So, well, the answer is no, we can't extrapolate that. What I should mention, although this wasn't a donor selection issue, but it's a stem cell source issue, bone marrow versus peripheral blood, we see a lot of cytokine release syndrome using peripheral blood between day 0 and day 3 after the transplant. And I think that what we need to do, so the problem that we have is that when we use marrow, things go really smoothly, but patients relapse. When we use peripheral blood, it's incredibly it's a very difficult experience with lots of cytokine release syndrome, some renal failure, very, very tough on elderly patients, but the relapse risk is lower. So I think to get a nice compromise between the two, we probably should be taking peripheral blood and depleting T cells, but adding back graded doses of T cells to find the right T cell content for a peripheral blood graft. Does that
Thank
make
you.
sense?
Sure.
But the answer is, a priori, I would say that, like, class 2 mismatching should be better in peripheral blood transplants, but what I can say is that it's that class 2 mismatching, we published this recently, that is actually responsible for post-transplant fever and probably for the cytokine release syndrome.
Okay, thank you.
Suparno?
I think we have discussed this out of the meeting a couple of times, but you will be held on to that data of yours where you have shown that older SIBs are better than younger offsprings. I mean, that's in your name. I mean,
Yes.
You might refute the data, but people are going to quote it and say that I would rather use a 56, 60-year-old sibling, matched donor sibling, over a 20-year-old offspring. So, we all know that age is a factor which matters. And again, I would reiterate what I showed in the morning, that age is a surrogate. Age is a surrogate for something else. And what we found in our data is that it is the graft content which ultimately would matter. And what in the graft is impacting the outcome, that is open to debate, but we have found a particular subtype or subset of regulatory T cells which are impacting the outcome. We are further exploring the other components of the graft, and we might come up with something else in due course, but this is an open area. We have not, we have done purely PBSC grafts, and we have, on our AML publication, we did not find any impact of HLA mismatch on the outcome in terms of adverse outcome. Neither did it impact the, relapse, etc.
Yeah.
But what I would, like to say is that, it's another area, that is when you are talking of DSA. As I told in the morning also, the major problem in non-malignant transplants is DSA. And what we are seeing as DSA is a surrogate for your T-cell mediated rejection as well. You might escape the B-cell mediated rejection, but ultimately you're facing the T-cell mediated rejection. And what I noticed that you're using upfront anti-T cell immunosuppressants in your DSA protocol, right? And with that in mind, I suppose, because if you're using tacrolimus and mycophenolate, you're more directing towards the T cells. So that needs a mention that,
Right.
Despite your clearing of the B cells, immunoglobulins, you might still be at risk of T cell mediated rejection.
Right.
So that needs to be taken care of. Do we agree on that you are still at risk of T cell mediated rejection?
Yes. Well, so I think you covered 4 different points there, so I'm going to try to take them one at a time. Now I forgot the first point. Oh, no. The first point was an interesting one. I forgot it, but this.
The first point was your data on SIBs, older SIBs and younger offsprings.
Right. So I went into that study thinking, okay, the answer is going to be that haplosibs, for the younger group, haplosibs and mat-sibs, would do about the same, and that for the older group, haplochildren would do better than the older mat-sib. And it came out exactly opposite of what I wanted it to come out. So if you're inclined to cheat, you close up shop and you never report it, right? So we reported it. But I think the answer is that, at least in the short term, the outcomes are better with the mat siblings because of the lower graft failure rate. And why is graft failure a bigger problem in child into parent transplants? Well, one, because you can have recipients who are mothers who are sensitized. There was a slightly higher graft failure rate when the recipient was a woman receiving their child's graft, but it wasn't significantly higher. But the other issue is, and this gets to the issue about, like, what's the difference as you get older? I think that the difference is the proportion of memory T cells in the graft, naive versus memory. There's more memory T cells. When you're young, just mentally, you're more flexible, and then as you get older, you get really set in your ways. And the T cells are the same. They get very set in their ways, and they just don't accept anything new, and they tend to reject everything. So that's point number one. The other thing had to do about class 2 mismatching and outcome. We have found it. I think Assad Bashi and colleagues at Georgia reported on improvements with class 2 mismatching, although they saw the benefit was actually with non-relapse mortality rather than relapse. And I think Rizwan Romi at your institution has also found some benefit of class 2 mismatching on outcome as well. There's something there, and I should say, class 2 mismatching does correlate with clinical phenomena. I mean, we see higher incidence of post-transplant fever with class 2 mismatching in the graft versus host direction. So CD4 T cells are inducing this macrophage activation and fever and all that kind of stuff. And I'd be interested if your HLH problem is more of a problem with class 2 mismatch donors.
Sorry, Effie, I was just going to say, class 1, you might expect to have a benefit if you believe the NK GVL effect, right? So HLA-C, mismatch, you might think an NKG2D ligand being mismatched would be a good thing to have. So it's surprising to me that you actually...
So it turns out that it's worse.
Right.
When we looked at ligand incompatibility, it's worse. Now, I have a crackpot theory as to the benefit of class 2 mismatching, but I think it'll turn out to be correct in the end, which is that cancer is a deficiency of CD4 help, okay? I mean, when you're trying to fight off a chronic viral infection like HPV, you need continuous sources of Th1 CD4 help. And if you lose that help, the CD8s become exhausted, and then you have a persistent infection, which can turn into cancer. Cancer is no different. You have a nascent cancer with neoantigens. If you can sustain a Th1 response and keep those CD8s going, you'll eliminate the cancer, and if your help dies out, you'll become tolerant, the CD8s will become exhausted, and the cancer will grow. So when you do a haplotransplant, you're introducing this fresh source of really alloreactive memory help, and it comes in, and in that period, and since you're giving non-myeloablative conditioning, you have this period of time where donor CD4s are interacting with recipient CD8s that are tumor-specific, and you are reviving an endogenous anti-cancer immune response, which can help contribute to the lower risk of relapse. Now, that, the endogenous response will get eliminated, but the fact that you've got alloreactive help, I think, helps promote the anti-tumor immunity by CD8 positive T cells, whether it's donor or host.
Thanks for that excellent talk. You've answered one of my questions between what John and Suparno asked, so I'm not going to repeat that. The other is a more practical issue. A lot of the work from DSAs come from solid organ transplants, and they tend to have a restrictive transfusion policy to reduce the allosensitization and other stuff. Is that something that you practice or recommend in the haplotransplant situation?
No, we don't. I think the biggest problem with solid organ transplants, you can't use an ABO major incompatible donor because red blood cell group antigens are actually expressed on vascular endothelium of the graft, and you can get accelerated rejection based upon the red blood cell antigen incompatibility, but that does not seem to be a problem in hematopoietic cell transplantation. However, what I will say, sorry to go on too long, is that we really avoid major ABO incompatibility when we're doing transplants for sickle cell disease, because there we use ATG as part of our conditioning. We'll end up with mixed chimerism. And when you have mixed chimerism, you'll have this hemolytic, you'll continue to hemolyze the donor red blood cells. And so you can have real problems with anemia post-transplant if it's, non-malignant disorder.
Thank you. My question was also from the aspect of HLA match platelet transfusions and other stuff. Is that something should be thought about, or it's too difficult to implement actually, because a lot of these patients get referred from elsewhere?
To avoid sensitization, you mean? I guess, but I mean, platelets probably don't have a lot of co-stimulation to sensitize. You're an immunologist. Can you help me out on this one?
Leukoreduction is what we need
Yeah.
To reduce sensitization as much as possible.
Thank you, Dr. Fuchs. This was a beautiful talk. I think we're supposed to actually have a break, but we have only one more talk, so I think we will go ahead with the last talk. So I would invite John Corrett, to come and talk about the state of the art in chronic graft versus host disease. That's probably our challenge after relapse. That's probably the next biggest challenge after transplant. John, over to you.
Thank you very much. I really appreciate the opportunity to present. On this talk, really a bunch of it is reviewing the state of the art. I'll discuss a little bit on some of the work that we're doing, but that's just trying to be within the broad clinical picture. I'll have a separate talk, I think, day after tomorrow, where we're talking more about regulatory cells. Jumping straight in, I think this audience is very well aware, so I'll be very brief. Over half, arguably, of our recipients of usual matched transplantation with calcineurin inhibitors and methotrexate do develop chronic GVH. This is a condition which is an important cause of morbidity, mortality. I think we all accept that. It's equivalent to living with major autoimmune diseases like lupus or MS. Even for patients who respond to steroids, you often need 2 to 3 years of chronic steroid exposure, and when you try to taper, you often experience relapse. The biology of what goes on in the background is fairly complex. It is more complex than acute graft versus host disease, which is primarily T-cell mediated, but I will summarize it as saying it's a multi-system inflammatory disorder. There are protein clinical manifestations highlighted by fibrotic responses, as noted, for instance, in the lichenoid plaques in the mouth of this patient. There is allo and autoimmune T and B cell activation. There is a documented deficiency of circulating regulatory T cells with an enhancement of the GCB reaction in the lymphoid organs, resulting in the production of pathogenic autoantibodies, and the combination of all of these results in extensive chronic inflammation, tissue injury, and fibrosis. I have very briefly listed here some of the multi-system involvement that we see in chronic GVHD. I will highlight that what we don't see that is common in acute GVHD is colitis of the large intestine, of course. So what we do describe here is more of fibrotic strictures and webbing, and indeed a variety of other fibrotic manifestations, of which bronchiolitis obliterans, the involvement of a chronic lung inflammation, has a very much increased risk of mortality from chronic GVH. So the treatment strategies are pretty straightforward, despite this entity being around now for getting close to 50 years. What we say is, number one, if you don't need to give systemic therapy, don't. Use topical agents as far as possible, if it's your eye, your mouth, your skin, your GU tract. If you do have significant systemic symptoms or multiple sites of involvement, then yes, you need systemic therapy. If so, prednisone at some dose. We typically say try to keep it below 2 mg per kg. We're increasingly going towards the lower doses if possible, with or without the addition of TAC and cyclosporin, which in randomized trials has suggested a benefit primarily in bone health. The response rates to these would be a third to half the patients, of whom the failure-free survival would be around 50% at 1 year. As previously mentioned, if you respond, you still need to be on therapy a long time, but thus far, additional agents at the onset of chronic GVH are not beneficial. Second-line therapies, leaving aside the story with ibrutinib that I'm going to get back to, I have listed here a variety of alternative therapies, highlighting the variability of response rates, but broadly suggesting that some of them, particularly ECP, might be quite well worth considering if facilities are available. The treatment choices at the end of the day, however, are not based on response rate data, because that is a heterogeneous patient population, often with a non-randomized comparators and single-arm studies. So it's based on availability, your experience of using the drug, how easy is it to use the drug for the patient, how often do you need to monitor the patients, and of course, what kind of AEs do you expect with the drug. Moving on from those agents that have been described over the past several decades, here is a schema that we laid out fairly recently in a review article in Blood, saying that really what we need to target is both the alloreactive T cells and the B cells, whether that be through graft engineering, whether that be through signaling, or indeed whether that be through the biology of regulatory T cells, which potentially could impact both axes. So the novel approaches I'm going to highlight are the B-cell depleting monoclonal antibodies, a variety of tyrosine kinase inhibitors, specifically imatinib, ibrutinib, and ruxolitinib, and then tolerance induction through our work in IL-2. So the anti-B-cell therapy, the story goes back to work with Jerry Ritz, Dave Miklas, and then Corey Cutler, where we showed that in patients post-transplant, there was a autoantibody scenario against the minor histocompatibility antigens in the context of a sex mismatch graft against HY antigens that precede the onset of chronic GVHD and whose occurrence correlates with both the occurrence of chronic GVHD and a reduction in relapse risk. Subsequent work led initially in the Ritz lab and then with the Sarantopoulos lab has shown that BAFF levels and BAFF to B cell ratios are also predictive of chronic GVHD, BAFF, of course, driving the survival and proliferation of autoreactive pathogenic B cells. So the phase 1-2 trial that Corey reported now over a decade ago was fairly simplistic, where you gave Rituxan at standard lymphoma doses, weekly ×4 with the option of a repeat at month 3, and this was for steroid refractory chronic GVHD patients. And what that trial showed was, number one, Rituxan works. You actually have a depletion of the CD19, CD20 positive cells that returns at about a year. And secondly, it reported highly promising response rates of 70%, primarily partial responses with significant ability to taper steroids. So that led to a variety, that added to a variety of other publications ranging in size from 3 to over 100 patients with a variety of Rituxan dosing schedules, reporting generally promising response rates, typically above 50%. And that subsequently led to a randomized trial, a phase 2 study for patients with cutaneous sclerosis who were randomized to Rituxan versus imatinib. Importantly, a crossover was allowed if there was inadequate response to therapy. So before I discuss that, I obviously need to talk about imatinib. The reason imatinib is relevant in chronic GVHD is because of autoantibodies that actually are against PDGF receptor, but result in its activation. This is a slide that Dave Miklas kindly shared with me, highlighting the fact that patients with extensive chronic GVHD have higher levels of these antibodies, and the way this is believed to work is through the ultimate activation of ERK and RAS signaling, resulting in increased actin, collagen, and fibrosis in the target organs. So the excitement around that was obviously the fact that imatinib didn't just block BCR-ABL, but actually had fairly high potency with regards to blocking PDGF. So various publications highlighted its potential role in advanced refractory chronic GVHD, although at the time caveats were noted where responses in patients did not correlate with the occurrence of a PDGF antibody, at least based on ELISA technology. You were equally likely to be a responder or non-responder whether or not you had the presence of these higher levels of pathogenic autoantibody. Nonetheless, Attilio Oliveri and his colleagues in Italy subsequently reported a single-arm phase 2 study, reasonably large size, 35, 36 patients, using fairly standard doses, 100 ramped up to 400 milligrams of imatinib, and while some AEs were reported, overall promising response rates of 50%, including the gut, the liver, the lungs, and the skin were reported, and responders appeared to do well in terms of survival, which was statistically better than those who were non-responders. And importantly, response was based on the NIH consensus scoring. So when the trial was reported, it was quite a disappointment. I'll just go over again. The trial had about 70 patients.